Good morning. I'd like to call this hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, January 29th, 2025. The time is 9:31 a.m. Today, we will discuss the FY24 performance of the DC Health Benefit Exchange Link Authority, also known as HBX or DC Health Link, as well as the Food Policy Council. This is a hybrid hearing with witnesses testifying virtually via the Zoom platform as well as in person. The DC Health Benefit Exchange Authority, or HBX, is a quasi-government agency of the District of Columbia charged with implementing and operating the district's health benefit exchange. HBX operates DC HealthLink, an online marketplace for district residents and small businesses to compare private health insurance plans, learn if they're eligible for tax credits or subsidies, to purchase private insurance or qualify for Medicaid and enroll in a health plan that best meets their needs. HBX enables individuals and small businesses and their employees to find affordable and easy to understand health insurance. The committee sent written pre-hearing responses or questions rather to HBX. We did that for all of our agencies, and we'll reference those throughout today. I'm just starting with the opening for HBX because they will go first, and then I'll talk a little bit about the Food Policy Council when we get to them. I don't see any of my colleagues who have joined, but if they do, we'll certainly turn to them. If anyone wants to see the pre-hearing responses, it could be found on the council's website at dccouncil.gov/hearings if you just click on this hearing. So we're going to turn to the public witnesses for both HBX and Food Policy Council. Before we get started, I just want to review the testimony guidelines for folks. Everyone will have 3 minutes, the public witnesses. I will give you a nudge when your time has expired, and if you're testifying virtually, you'll need to accept our invitation to become a panelist once your name is called. Now, the 3 minutes is not because we don't want to hear all that you have to say. The 3 minutes is because we want to hear all that everyone has to say. You are certainly welcome to include more information in your written testimony. All right, I'm going to call our first panel of public witnesses, and these are folks who are here in person. Sia Barbara Kamara, Ann Gunderson, who's a senior policy analyst at DC Fiscal Policy Institute. See Ann, Audrey Kesselman. Who's Audrey? Destiny Bolton from Spaces in Action. I don't see Destiny. Tara Vasby. Okay. Sorry if I pronounced it incorrect. And Julie Lujan. Julie is here. Oh, she's virtual. Okay. Okay. Is there anyone in person now who wants to testify because I have an extra seat? Okay. All right. So we'll get started. Ann, when you're ready.
Great. Excuse me. Chairperson Henderson, members of the committee, thank you for the opportunity to testify. My name is Ann Gunderson. I'm a senior policy analyst with the DC Fiscal Policy Institute and a member of the Under 3 DC Coalition. Healthcare for Childcare makes free or low-cost health coverage available to childcare workers who live in the district and non-district childcare workers whose employers purchase coverage through the DC Health Benefits Exchange. To date, more than 1,800 educators and their families have benefited from healthcare for childcare, many of whom are receiving employment-based healthcare for the first time. Many educators have testified before the council about how life-changing this program has been for them. And every dollar DC invests in healthcare for childcare nets over $1 in premium value, making it a beneficial program for the entire district. Yet, the DC Health Benefits Exchange recently instituted a waitlist for new childcare facilities enrollment and healthcare for childcare coverage due to insufficient funding. Prior to instituting the waitlist, the Health Exchange enrolled 79% of eligible childcare facilities in healthcare for childcare, a great accomplishment in just a few years. But that leaves almost 60 facilities across the district without access to group coverage through healthcare for childcare and subject to the waitlist unless more funding becomes available and other facilities drop out. The Health Exchange successfully extended healthcare for childcare to the facilities in every ward, but participation varies considerably. For example, wards 7 and 8 have the smallest percentage of facilities enrolled in healthcare for childcare group coverage. This gap will persist if the budget does not allow for more childcare facilities to enroll in healthcare for childcare. DCFPI is grateful that the Health Benefits Exchange continues to work diligently to ensure that educators living in DC who are at risk of losing Medicaid coverage due to earning higher salaries are pulled into healthcare for childcare for individual coverage. We recognize that their commitment to creating a well-designed healthcare program is one reason why the Pay Equity Fund has been so effective at attracting more educators to early childhood classrooms, increasing the retention of qualified educators, and expanding access to high-quality, affordable care to district families. Their deep commitment to provide coverage to as many facilities, educators, and families as possible has allowed this program to thrive. The Health Exchange also thoughtfully engaged the community and facilities via outreach events, and an advisory council engaged the Under 3 DC Coalition in policy decisions and kept us updated on critical administrative changes, pulling us in as partners to expand the reach and efficacy of healthcare for childcare. Yet the limited budget for healthcare for childcare is now stymieing progress towards the ultimate goal of early educators having access to healthcare when they choose to work in any district childcare facility. We look forward to continuing to work with the Health Exchange to ensure that they have the resources they need to continue this important work. Thank you, Councilmember Henderson, for your steadfast support of the Pay Equity Fund and Healthcare for Childcare, and thank you for the opportunity to testify. I'm happy to take questions.
Thank you, Anne. I just want to, oh no, she just walked out. She'll be back. Okay. Audrey.
Good morning, Chair Henderson and staff. My name is Audrey Castleman, and I'm a senior policy analyst at DC Action and the Under 3 DC Coalition. First, I would like to thank the council for its continued commitment to early educators and to extend my gratitude to you, Councilmember Henderson, for your leadership in ensuring the Pay Equity Fund and Healthcare for Childcare remain a priority for the district. The Healthcare for Childcare program is the first publicly funded health insurance initiative in the country designed specifically for the early childhood workforce, including early educators and non-teaching staff. Since its launch in 2022, it has provided free or affordable, high-quality health insurance to nearly 2,000 people, including early educators, staff, and their families, addressing a critical gap in employer-sponsored health insurance coverage that has long plagued the field. Research from Mathematica highlights that investments in healthcare for childcare and the Pay Equity Fund together increase job satisfaction, reduce financial stress, and improve health outcomes. A healthier, more satisfied workforce is better equipped to provide consistent, high-quality care for young children, a critical factor in their social, emotional, and cognitive development. At a Pay Equity Fund Task Force Roundtable last year, one participant shared that the Healthcare for Childcare program gave them peace of mind, enabling them to focus on their essential work with children. Before Healthcare for Childcare, the majority of early learning facilities in DC could not offer employer-sponsored health insurance because it was too expensive to do so. Healthcare for Childcare has changed that, particularly for smaller facilities and home-based providers in underserved areas, making the provision of affordable healthcare benefits a possibility for many facilities for the first time. Despite its success, Healthcare for Childcare is vulnerable to political funding debates. In late 2024, Healthcare for Childcare began requiring a wait list for new childcare providers due to funding limitations. Without additional funding to reopen enrollment, the health and financial stability of many educators and staff and the stability of the early learning system as a whole are at risk. The stakes are high. Healthcare for Childcare is not just an investment in our early learning workforce, but in our children, families, and the long-term equity and prosperity of the district. I urge the council to prioritize funding for this program when FY26 budget deliberations begin to ensure that every eligible educator and staff can access the benefits that they need to thrive. Ensuring educators have access to affordable health care is essential for retaining this vital workforce and providing the high-quality care and learning experiences that our youngest children deserve. Thank you for the opportunity to testify today, and I welcome any questions.
Thank you, Audrey. Julie.
Greetings, members of the Committee on Health. Thank you for allowing me to speak today. My name is Julie Lujan. I'm the owner of 2 child care facilities in Ward 1, Lanier Lullabies and Child Development Home. I'm also a mother of 4 who lives in Adams Morgan. Since 2007, I've provided care for over 260 children and jobs for 51 employees. I'm writing today to encourage you to continue to fully fund healthcare for childcare and the Pay Equity Fund. I have experienced the power of this program on the well-being of the teachers, their families, my early learning programs, and me personally. Prior to healthcare for childcare, I was not able to offer health insurance to my staff and was paying 100% of my family's health care. I have always been a small business owner and been faced with the crippling expense of finding individual health insurance. I have paid about $2,700 a month for health insurance for my family for decades. Like many people, my family is faced with multiple health issues that could easily bankrupt us with a single unexpected medical bill. In 2022, my daughter was critically ill, needing extensive medical treatment I could not afford. My husband and I waited anxiously for our new cards to arrive and the benefit descriptions as soon as it turned 12:01, January 1st, 2023. We had done our research on her treatment options and we were ready to get her the help she needed. She was finally able to receive her life-saving treatment in February 2023, thanks to Healthcare for Childcare. She is doing great and attending Montgomery College and has a bright future ahead. If I had to delay the care longer because the council did not adequately fund the Pay Equity Fund, which is where Healthcare for Childcare receives its funding, my story might be different. We all know that the health insurance system in the U.S. is broken, but Healthcare for Childcare was a step towards fixing the broken system and thinking outside the box. When I had first heard the whisper of a chance that childcare providers would be offered health insurance, I thought for sure it was too good to be true. The significance of this cannot be overstated. I am incredibly grateful to Councilmember Henderson for ensuring the creation of the Pay Equity Fund in 2021 and that it included the establishment of the Healthcare for Childcare to provide affordable health insurance to early educators and staff. The program's creation guaranteed that educators could enroll in coverage. However, that promise is at risk with the recent implementation of the Healthcare for Childcare waiting list due to insufficient funding. In conclusion, I urge you to consider the profound impact the Healthcare for Childcare on the early care and education workforce. By providing affordable health insurance, this program supports the physical and mental well-being of our dedicated professionals and strengthening the quality of the care provided to our children. Thank you.
Thank you. And thank you to all of the witnesses for your testimony. I think healthcare for childcare is probably one of the favorite things that I feel like we've done, or at least in my first term that we did, and it's super impactful. Ms. Lujan, well, I see Ann and Audrey all the time, so it's always good to hear from an actual childcare facility owner and a business owner, right? I think that's the part that often gets missing in the conversations about early childhood is that these are small businesses. When you were, can you talk to us a little bit in terms of your employees' experience enrolling in the program? I think you mentioned you have 51 employees across your two facilities. Oh, you just got to turn your mic on.
So currently I have 13, but
13,
over the
okay.
years I've had that many employees. So like enrolling in the process,
Yes.
process itself. So there's a great group from DC HealthLink that kind of specializes in healthcare for childcare. I forget their names. There's Brian, Jesus, and they so they're their main contacts and they're super responsive. It does get confusing sometimes about like who to talk to next in the whole process of getting signed up. But no matter what problem we've had, it's always been worked out.
That's good to hear. So Ann and Audrey, you both raised in your testimony the wait list that has had to be put in place. And Ann in particular, you noted that Ward 7 and 8 has the lowest number of facilities that are currently enrolled. Have you heard from those facilities? Now, obviously, when we first rolled out this program, there was a bit of hesitation at the beginning, I think, from some of the facilities in terms of taking this on or, they don't want to be the first ones to do something. And then after a while, more and more kind of grew. Are you hearing specifically from these Ward 7 and 8 facilities that they want in, but they're kind of upset that they missed the first boat?
I think more of what we're hearing in conversations with Mila and her team at the Health Benefits Exchange, they were able to reach the 79% penetration into the childcare facilities because of all of the outreach, the individual outreach to childcare facilities. And so now that they are no longer doing that individual outreach to childcare facilities, they're not actually anticipating like folks knocking on their door saying, hey, we got to get into healthcare for childcare, just because of the muddledness of offering employment-based group coverage in DC.
Mhm.
So I think more so what we're going to experience is more of a knowledge gap between these facilities who are a bit left behind because no outreach is happening because they're not able to pull them into healthcare for childcare.
Yeah. Okay. For those who are tuning in, we had to put a cap on the program because of budgetary reasons last year to try to save what we already had. But we will see what happens in April when we get the budget. I don't have any further questions for you all. If you could just make sure that you have provided your testimony for the record. And thank you so much for your time. Thank you. Okay. We'll go on to our next panel. I'm gonna do I'm gonna start with panels of 6, given what's on my list. But I also think we just had some folks who came in who had signed up to testify in person who were not here on time. Is Destiny? Okay, Destiny, you'll be the only in-person person for this next panel, and then we'll go on to the virtual. So Caroline, sorry. Sia Barbara Kamara, Caroline Winkler, Latoro Alejo, apologies if I'm getting it correct, Claire Heisen, Brett Allen, and Floyd May. Again, for the virtual folks, you need to affirmatively accept our invitation to become a panelist in order for you to be promoted and to join us. But Destiny, you're here, so why don't you go ahead and get started? Yeah.
All right, good morning, council member and committee members. My name is Destiny Bolton, and I am a community organizer with Spaces in Action. Spaces in Action is a grassroots nonprofit organization. Our organization advocates to increase early childhood learning opportunities and increase access to health equity. As an early childhood organizer, I'm here today to provide testimony regarding healthcare for childcare. I am deeply rooted in my community and hold strong values for supporting early child care educators and recognizing the critical work of early learning professionals across the District of Columbia. These values matter to me and align with who I am because I'm a recipient of early childhood education. I'm living proof of its importance and the vital role it plays in human development. Quality early learning child care lays foundation for lifelong learning, confidence, and success, which is why investing in and supporting early educators is essential for the well-being of our communities. One major problem early childhood educators face is the potential loss of healthcare coverage if the pay equity fund is eliminated or underfunded. As part of this initiative, Healthcare for Childcare provides free or low-cost health insurance for early childhood employees, ensuring they receive the care they need. Kiera Fernandez, the Assistant Director of Blondie's Child Care Center, is a direct recipient of Healthcare for Childcare. She shares, Healthcare for Childcare has greatly supported Blondie staff by easing our financial burden and providing security. We recently hired 2 new staff members who lacked health insurance, and programs like this made them more eager to work for employers that offer such benefits. We can now schedule our health appointments with confidence, knowing we won't be turned away or burdened by overwhelming medical bills. The solution to this issue is sustained and increased investment in early childhood education. I urge the council to allocate an additional $20 million to OSSI's fiscal year budget. This funding is crucial to maintain essential programs such as healthcare for childcare, the Pay Equity Fund, and childcare subsidy, programs that directly support families and early childhood educators across the district. Thank you, council members and committee members, for hearing my testimony.
Thank you. All right. Ms. Kamara.
Well, good morning, Councilmember Henderson, members of the committee and staff. I'm Cia Barbara Kamara. I'm a longtime Ward 4 resident. I'm the Chief Strategy Officer for the DC Early Learning Collaborative, a member of the Executive Committee of the Under 3 DC Coalition, and also a member of DC Association for the Education of Young Children. Today, I testify about the successful implementation of the Healthcare for Childcare program by the DC Health Benefit Exchange Authority under the leadership of Mila Kaufman and her team. This team is a sterling example of how public servants collaborating with strategic and trusted partners in the community can successfully implement a much needed benefit to increase healthcare coverage in the district. Currently, almost 2,000 people, early childhood educators, staff, and families participate in the Healthcare for Childcare program. Most early learning programs enrolled in Healthcare for Childcare did not offer healthcare coverage for employees prior to this program. So this program means that nearly 2,000 people, as you've already heard, have become better able to access preventive care, pay for necessary medical appointments, and rely less on emergency rooms or for primary care. DC leads the nation in early childhood initiatives on multiple fronts, including access to early learning programs, educator pay equity, and now healthcare for childcare. None of this would be possible without the vision and leadership of the council and collaborative agencies working thoughtfully and transparently with the community partners like DCELC and Under 3 DC. We truly appreciate this partnership. In 2023, the Health Benefit Exchange established a Healthcare for Childcare Advisory Committee when they realized that they needed additional support through outreach to this particular community. The grantees have also promoted healthcare literacy to ensure workers enrolled in the healthcare program know how to maximize their use of health insurance. The 5 early childhood associations and community-based organizations funded through this program played a significant role in helping bring healthcare coverage to as much as 50% of DC's early learning workforce and their families, creating positive short and long-term impact for individuals and community health. The district can build on this progress by restoring full funding for the Healthcare for Childcare program. The district must continue to prioritize healthcare for childcare alongside increasing salaries of early educators. Health insurance is a key component of fair compensation and is necessary to grow and retain a stable, high-quality early learning workforce, which has a proven positive effect on children's health and development. We look forward to continuing to partner with the Health Benefit Exchange Authority to identify and implement innovative ways to promote a fully funded healthcare for childcare program. Thank you, and I'm available to answer questions.
Thank you. Caroline Winkler.
Hi, can you hear me?
Yes.
Great. Good morning, council member and staff. Thank you for the opportunity to testify today. My name is Caroline Winkler, and I am a self-employed local business owner. I'm here to testify as to how I benefited from the health benefit exchange while in the midst of some unexpected life events, and particularly how I benefited from the special enrollment period process. My livelihood is as a YouTuber. I support myself by creating video content online, and like many other local business owners, I rely on the DC Health Benefit Exchange for my health coverage. Unfortunately, at some point in 2024, I unwittingly became the victim of identity theft, and as a result, had to cancel many of my credit cards that had been compromised. Unbeknownst to me, this also terminated several of my automatic payments towards my healthcare, creating a lapse in my healthcare coverage for several weeks before I realized the issue. Once this issue came to my attention, I was extremely distraught about this lapse in healthcare coverage outside of the normal enrollment period, as I had several ongoing medical concerns, including recent knee surgeries. However, I happened to talk about my worries regarding this lapse in healthcare coverage in a YouTube video I posted, and that video happened to be viewed by a public information officer, Kelly Whittier, who works with the Health Benefit Exchange Authority, and who kindly went out of her way to reach out to me personally and inform me of the special enrollment period process, a process which was able to reinstate my health coverage even outside of the regular enrollment period. I'm grateful to testify today to express my gratitude for and the importance of the special enrollment period process that supports local business owners even if they lose coverage due to what are often unexpected life events. Thank you.
Thank you. Latoro? Don't see. Claire Hyson? Don't see Claire. Brett?
Can you hear me?
Yes.
Great, great. Good morning, Chairwoman Henderson and members of the committee. My name is Brett Allen, Director of Government Relations and Public Policy at the DC Chamber of Commerce. The DC Chamber is pleased to submit testimony on the performance of the DC Health Benefit Exchange Authority over the last fiscal year. The DC Chamber represents approximately 1,100 member companies, all sizes and industries, and the hundreds of thousands of individuals they employ. Through our longstanding partnership with DC HealthLink, we have conducted wide-ranging outreach to connect businesses across the district with the exchange, and we have worked closely with brokers to assist the enrollment in health insurance offered through the small business online marketplace. We are particularly proud of the fact that the district has the second lowest uninsured rate in the nation, with nearly 97% of our residents covered. The DC Chamber's ongoing small business partnership with DC HealthLink includes outreach and enrollment campaigns designed to inform small business owners about the array of plans offered by the exchange. Our outreach also includes posting DC HealthLink information on the DC Chamber's website and our social media, including flyers, banners, and press releases. We have also sent more than 900 marketing and promotional materials, emails, social media messages. We made over 350 in-person connections with small business owners and referred over 50 businesses, resulting in the enrollment of at least 10 new small business enrollees. The DC Chamber also hosts 25 events yearly, and we seek to promote DC HealthLink at every appropriate opportunity. The DC Chamber also participates in the DC HealthLink's special campaigns such as Power Up DC, which celebrates and supports the small business community by providing enriching business resources and networking opportunities through a range of cutting-edge seminars, special events, and focused presentations. Our annual events provide perhaps the greatest opportunities to promote the benefits of DC HealthLink. Last spring, DC HealthLink participated in both our 2024 Health Policy Forum and our State of the District and Region Conference. Executive Director Mila Kaufman served as a panelist for both events, addressing collectively over 200 attendees. The DC Chamber also recognized DC HealthLink as a partner at our annual gala, attended by approximately 800 business leaders employees, residents, and government officials. In 2025, the DC Chamber and DC Health Link look forward to continuing to build on our past successes. But I would like to take a brief moment to address a topic of great concern for the exchange and the district's small business community. As you may already know, lower premiums provided under the American Rescue Plan in the way of enhanced tax credits are set to expire at the end of 2025. If Congress does not act by extending those tax credits, premiums will spike and millions of working people and middle-class families across the country will lose their health insurance. This would have significant impact on the district as thousands of district residents will become uninsured, including many small business owners. I'll wrap up. The DC Chamber is committed to working with the exchange to urge Congress to act. We have already begun efforts with DC Health Link and its partners to develop advocacy strategies to engage key congressional members while also coordinating our advocacy with other chambers of commerce in impacted jurisdictions. As this committee reviews the performance of agencies under its purview, we would like to underscore that keeping premiums low and providing a richer way of plan choices are of utmost importance to district residents and businesses.
Thank you
for the opportunity to testify.
Thank you. Mr. May.
Good morning, Chairperson Henderson and members of the DC Committee on Health. My name is Floyd O'May. I am the Executive Director of the Leadership Council for Healthy Communities. I am also the Chair of the Washington, DC NAACP's Housing Committee. I am pleased to provide testimony at this hearing for LCHC, an organization of clergy leaders, medical professionals, public and community leaders working together to help African Americans and other communities of color to eliminate health disparities and promote healthy communities through comprehensive health programs. LCHC has had the privilege of serving as a sister organization of the Health Benefits Exchange since its inception in 2013. This past year, we have provided support working diligently with the important work of the Medicaid unwinding effort. LCHC has supported the vigorous Medicaid unwinding outreach effort, making phone calls and sending emails to persons identified for Medicaid unwinding. LCHC assisters have over 140 calls reaching out to Medicaid unwinding consumers and sent over 200 emails. One successful outcome because of Medicaid unwinding outreach is Sarah's story. Sarah felt overwhelmed and troubled and unsure how to explore her options for health insurance after losing her Medicaid coverage as a result of her change in employment status and income taking her out of the realm of eligibility for Medicaid. After receiving an outreach call, she scheduled an appointment to meet with an LCHC assister at the MLK Library. The assister was able to provide direction in navigating the DC Health Link. This resulted in Sarah obtaining a QHP plan, which was affordable and met her needs. An intentional outreach effort was also made to get to the hard to reach people at accessible and convenient locations. LCHC maintained a regular presence at several physical locations for convenience and ease of access for consumers to enroll in health insurance with DC Health Link or to get information. These locations included Martin Luther King Library, evenings and Saturdays, preventive measures, health clinic 4 days a week, and the DC Department of Employment Service, the Bacchus campus for 3 days a week. Additionally, our assisters participated in one-touch events, both in person at Carlos Rosario and virtual evenings and Saturdays. Being a faith-based organization, we utilize our network of faith institutions to not only disseminate information on the DC Health Link and Medicaid unwinding, but we were able to enroll on site on Sundays as well as participate in their activities such as health fairs, Blueprint for Wellness, and wellness events. Clergy were encouraged to deliver messages from their pulpits to disseminate information about the importance of having health insurance. It was important to say to stay informed about the Medicaid unwinding effort. So all LCHC assisters regularly participating in Medicaid unwinding training sessions. LCHC actively participating in outreach efforts at the request of the Health Benefit Exchange Authority, including open enrollment kickoff at the Mayor's Winter Community Resource Fair, the Latin American Youth Center event, the
Mr.
Economic
Mayor.
Employment Summit. Yes, ma'am.
Sorry, you're about a minute over, so if you could wrap up. We have your written testimony.
Okay, thank you very much. Well, LCAC outreach efforts has provided widespread opportunity to enroll persons in health insurance on educating conference, and we are committed to continue that engagement. And we thank you for giving us the opportunity to testify on behalf of our support of the program.
Thank you. And Tara Vass. You gotta hit the button. There you go.
Good morning, Councilmember Christine Henderson and committee members. My name is Tara Vasafi, and I work at Centronia, a nationally recognized award-winning educational organization providing affordable, high-quality early childhood education, professional development to educators, and family support services in a bilingual and multicultural environment to more than 2,400 early learners. The vast majority are from low-income working families, mostly consisting of Black, Indigenous, and other people of color. I am so excited to offer this testimony today because I am a beneficiary of healthcare for childcare. It has been an awesome experience to actually, make it work, make health insurance work. And I actually feel like this might be a prototype for universal healthcare or the public option. And I'll tell you why. After a career as a human rights attorney and a director at a tech company, followed by a stint actually working at the Sustainability and Equity branch of the Department of Energy and Environment, it instantly became clear to me that in these unprecedented and challenging times, we need the brightest minds and most passionate advocates fortifying our foundational community-based and educational institutions. The benefits are not just for me personally, but there are considerable second and third order benefits of the Healthcare for Childcare program. First, due to the fact that childcare workers in DC are most often women and women of color, multiply the increasing insurance rates by the fact that childcare centers have a weaker negotiating position with insurance companies. I verified this with our director of HR. When we go in to negotiate with insurance companies, they instantly say, you have a lot of women, you have a lot of women of color, and that actually makes us have a weaker negotiating position, and also has increased since 2018. Our insurance cost has increased by 50%. Just this past year, it's increased by 22%. So the second reason why this is important is that although due to our size, Centronia has about 295 employees, we are unable to qualify for full coverage for healthcare for childcare. Only those who are DC residents are able to get that plan. Nonetheless, this has a great effect on our institution because basically we're saving a lot of money by having the healthcare costs covered through this program. Finally, as I explained, having access to high quality healthcare is a big factor in where I choose to work. A lot of people feel this way. So I'd like to propose two solutions. One is make sure that we fund the pay equity fund and this program fully, sufficient to meet OSSI's minimum required salaries. And then another idea that came from our director of HR is that if DC government can pool this and basically negotiate as a collective with the insurance companies, because those companies are so interested in having a large client like the DC government, that we have a good negotiating position. So I think there's actually a way of restructuring the plan so that you can include more people, which will actually have a better effect on costs. Thank you so much. And yes, thank you.
Thank you. Don't go anywhere. Okay, I might ask you some questions.
Oh, okay,
Yeah,
great.
Destiny, you want to come back to the table? Yeah. Thank you to this panel of witnesses for your testimony. I'm going to ask a couple of questions or say a couple of different things. First, Ms. Winkler, if you're still here, thank you so much for your testimony. I'm not familiar with your channel, but the fact that you got the attention of the PIO of an agency is pretty cool. And I'm glad that you were able to use the special enrollment period, which I think is a great offering for people. And I think it just sort of underscores as well that, right, only having open enrollment from November to December doesn't just align with regular life. Like things happen where you might need to transition earlier, and so I'm glad that you were able to work that out. In terms of obviously Kelly's great, but in terms of your relationship and talking with folks to help navigate through the process, how did that work for you once you called the agency to enroll?
It was fairly simple at that point. If I remember correctly, I simply had to provide a little bit of information and someone was pretty readily available. I'm afraid I actually don't recall too many of the details, but it was pretty painless once I was connected with them. I think the bigger issue was that I just really didn't have any awareness that there was a process in place specifically for that. It didn't seem super easily accessible at the time. But I know that Kelly in particular was working really hard to find people who were kind of reaching out for help aimlessly on the internet and point them in the direction basically of that process. But I believe it was, I provided a little bit of information, had to catch up on my payments. I did end up having to pay for the few months where there was that lapse in coverage.
Right.
And then I think by the beginning of the next billing cycle, it was reinstated. So as far as like the logistics, it was pretty seamless.
That's good. That's good to hear. I know we have a lot of people who are testifying today about their hopes for the future budget, but this is a performance hearing, so I want to hear about the work of the agency in the last year to actually do all the things that they said they were going to do. So thank you so much for being here, for your testimony. Mr. Allen, I thought you brought up a very interesting point, and thank you for being here and representing the chamber. I had a long conversation with several people yesterday, because yesterday was a day here, and especially we started talking about health insurance, but also what the future looks like, particularly as it pertains to some of these tax credits and who has benefited from the tax credits around that. And I'm curious from the perspective of the chamber, as we sort of move forward and talking about some of these tax credits, which you talked about, right? A lot of your folks, small businesses benefit from PTC or premium tax credits under the health, the American Rescue Plan. Ooh, there's so many acronyms, if you will. Is the U.S. Chamber of Commerce talking about this too? I'm curious.
Yeah, so right now we, that is there's somebody that I'm going to reach out to. I've been working with Mila, who can properly provide you a little more information about this kind of overall what's going on. But we're putting together a plan to get all the chambers involved, and especially I think the U.S. Chamber needs to be reached out to and certainly involved. Because it should be an all hands on deck.
Well, and I think also talking about the impact, right? Like, as I said to Ms. Lujan, who was here earlier, right? Childcare business is a business. It's a small business. Some of your members in terms of the Chamber of Commerce, whether it be a restaurant or a cleaners or otherwise, they are businesses who need health insurance and so are trying to figure that out. But Mr. Allen, if we could follow up more offline, if y'all have any particular data about your membership as it pertains to this, that would be, I think, very helpful. If you're cool with that.
Absolutely.
All right. Thank
Absolutely.
you. Tara, thank you so much for being here and for your work. And Destiny, thank you for the ongoing advocacy of Spaces in Action. I know that you guys have done a lot to mobilize childcare centers. When my daughter was in the center. I ran into you guys when I was doing pickup. And I think it's super important in terms of that on-the-ground work to just get folks informed, because as Ms. Winkler talked about, right, like there could be these great policy opportunities that are available to folks, but if they are not informed about the option, folks are kind of missing out on things. So, Ms. Vassy, I know you're not the head of HR for Centronia, but maybe you have a little bit of knowledge of this. Prior to healthcare for childcare, did Centronia offer healthcare for its employees?
Yes.
Okay, but even at the employee size, I think that's what you were saying around, like, we were already at a disadvantage due to the demographic makeup of the workforce. Is that correct?
Yes. And actually, I'll be submitting my written testimony once people higher up the totem pole can, check it off for me. But there's a little graph in there that kind of shows you the number of employees who were covered and, the difference of how much we were able to save once healthcare for childcare was enacted.
Yeah, I would love to, when you guys have that, we would love to see that information.
Okay.
Because I think this is important in terms of what we're talking about here. There are a group of people who never had health insurance, and then there are a group of people who had it, but it was very expensive for the business to continue to offer it. And so what happens there? I'm also going to ask you this, because I feel like one of the biggest misconceptions of the healthcare for childcare program is that no one is paying anything, that the government is paying for everyone's health insurance. Can you talk a little bit about the fact that how that's not true?
I actually can't, because I'm not paying anything. I'm getting free healthcare.
Yeah.
And essentially, I mean, as you said, childcare centers are a small business. And actually, now that I get an inside look, I honestly have no idea how they're able to make it work because of the way that reimbursements happen.
Yeah.
And nothing is fully covered. So childcare centers are always basically having to figure out how to take some money here and cover the basic costs. So as an example, our food, when we are required to give breakfast, lunch, and a snack to every early learner, our food is not fully covered. We get reimbursed a certain percentage of the federal government and then a certain percentage from OSSI or in Maryland, the equivalent. So that's shocking to me because it's we're contractually obligated to make sure that every child has breakfast, lunch, and snack, but there's no full coverage, even in a place that has universal pre-K.
There's no full coverage even for the school system.
Exactly, right? Exactly. So what happens is that even the little amount of money and I'll show you the chart, when we had 215 employees, 85, we had to cover, 85 were enrolled in our insurance. And then over time, now that we have about 295 employees, Centronia is paying about $1 million a year to cover 75 employees, which is a lesser percentage. So that frees up a chunk of money that we then move to be able to cover basic costs like food.
Yeah. So that's what let me revise my statement from before in terms of no one is paying. You might not be, but the business is still making a contribution to your health insurance.
Yes.
And I think that is the confusing piece where folks think that oh no, we're paying everything 100%, which is not what this is. I also thought that the part of your testimony around the collective negotiating piece, when we were first having conversations about the pay equity fund in general and trying to figure out okay, how do we do this? And frankly, it was the only jurisdiction that we could sort of point to was New York, and not for they don't have the pay equity fund, but they do have a number of their childcare centers that are unionized in a contract with the city. But it was that collective pooling that allowed for them to be able to talk about the salaries and the benefits and the da-da-da and the da-da-da, right? And so then we have to think about, okay, we're not going to unionize everybody, then how do we do it in other spaces? And the pool piece, I think, is so interesting that it hasn't really been explored in other ways, right? If you have a group of small businesses who are similar in size and things like that, could 15 or 20 of them come together and negotiate for healthcare as a unit?
Yes, and I'll give you a crucial data point on that one, which is that when I started working at Centronia, truthfully, the plan that was provided through Healthcare for Childcare was not that great.
Yes.
And then a year later, it's now like the gold standard. It's amazing. And shout out to Tawana Freeman, who also works at the Healthcare for Childcare. She's like the customer service person that I'm in touch with. So that's another thing that's really great about it, is that essentially you're not dealing with some random insurance work and company worker off nowhere. Like, she's a DC government employee and she's a neighbor of mine. I mean, you know, we're residents of
Yeah.
a similar area. So it's like, it's just a different relationship. And the key thing is that what I understood is the reason we were able to get a better plan was because of that negotiating power that DC government has, and also that the insurance companies were able to have some time to be able to, you know, do the actuarial math to give us a, you know, a more realistic and better plan.
Yeah. All right. Well, we'll talk more. Thank you guys so much for your testimony.
Thank you.
Thanks to this panel of witnesses. Mr. May, always great to see you and the work that you guys do with the Leadership Council. So thank you so much. We're going to go to the next panel. And please, everybody, make sure you turn in your written testimony so we can have it for the record. Alethea Etanoff, Che Rudol Jabasila, Nicole Quagroga, apologies for butchering, Elaine Reyes, Marcelina Romero, Dennis Angel, and Janice Davis. All right. Again, if you're just joining us, you'll need to affirmatively accept our invitation to become a panelist. Okay, I do see Ms. Etanoff. Alethea?
Yes. Good morning, council members. My name is Alethea Etnoff, and I'm here as both an employer in early childhood education and a parent. I'm not sure if you can hear me now.
Yeah, we can hear you. I can't see you.
I'm sorry. I want to express my gratitude to Councilmember Henderson for ensuring that the creation of the Pay Equity Fund in 2021 included healthcare for childcare, making affordable health insurance accessible to early educators and staff. This program is critical, but its promise is now at risk due to the recent implementation of a healthcare for childcare wait list caused by insufficient funding. The council must ensure that all early educators participating in the Pay Equity Fund continue to have access to affordable, high-quality healthcare. There are approximately 4,000 early educators in the district, and every one of them deserves reliable coverage. Additionally, the district must continue robust outreach to ensure all eligible educators are aware of and can enroll in this program, assuming full funding is restored. As an employer, I know firsthand the value of providing health benefits. As a parent, I hope that one day my children will finish their college studies and I'll be able to offer them employment with the health security they deserve. And I'd like to add that in FY 23 and 24, Healthcare for Childcare received $18 million from the Pay Equity Fund to provide health insurance for up to 75% of early learning programs in the district. Due to accommodate budget challenges last year, the health benefit exchanges said it could continue operating HC4C with $12 million to protect coverage of childcare programs already enrolled. However, it is unfair that early educators and all childcare program staff whose employers were late to join the Pay Equity Fund would be placed on a waiting list and prevented from accessing good quality, affordable care. And I urge you to fully fund healthcare for childcare and keep the promise made to early educators. Thank you.
Thank you. Che?
Good morning, Chairwoman Henderson and members of the committee. My name is Che Rudol Tabasola. I am Managing Director and Vice President of the Restaurant Association of Metropolitan Washington. On behalf of RMW, I'm honored to testify in support of the DC Health Benefit Exchange Authority and its operation of DC HealthLink. RMW represents more than 1,400 members across the Washington, D.C. region, encompassing restaurants, bars, commercial kitchens, caterers, food distributors, and a wide range of service providers. We advocate for the interests of our members and promote growth and success of the local hospitality industry. As a small business, RMW has been a customer ourselves of DC HealthLink's Small Business Health Operations Program, also called SHOP, since 2014. The food service industry is a critical pillar of the district's economy. According to the 2023 National Restaurant Association census, there are 2,624 eateries and bars in DC. And together we employ 64,800 individuals, or 8% of the city's entire workforce. Most full-service restaurants in the district are independently owned and operated as small businesses. RMW has partnered with DC HealthLink to ensure our members are aware and have the most current information about their access to quality, affordable healthcare operations for their employees through SHOP. During the fiscal 2024 year, we have deployed strategies to reach and engage small business owners, operators, and their employees through outreach, direct email and mailed information to an average of 200 district restaurants per month, 15 dedicated virtual sessions that provide a space for Q&A related to offering healthcare coverage, 42 industry training sessions where insurance coverage information has been provided to district residents, 15 events where attendees have been provided materials, and thousands of communications through our industry distribution lists and social media platforms that reinforce and highlight the benefits of coverage for small businesses and SHOP and district residents during the open and special enrollment periods. Similar to my colleague Brett at the DC Chamber, we are also working closely with DC HealthLink to inform and educate members of Congress through organized efforts with other business partners as well of the need to renew the rule that will keep insurance rate low, as the effect of losing the rule will impact more than 4,000 district residents who are micro businesses that currently can access affordable coverage as a result of the allowances of the Inflation Reduction Act. RMW is committed to supporting DC HealthLink and its mission to provide accessible and affordable healthcare coverage to small businesses and their employees. We believe that access to quality healthcare is essential for a thriving workforce and a vibrant hospitality industry. Thank you for this opportunity to testify, and I'm available to answer any questions you or the committee may have.
Thank you. Nicole?
Good morning, everyone. Good morning, Chairwoman Henderson. My name is Nicole Quiroga. I'm the president and CEO of the Greater Washington Hispanic Chamber of Commerce. I want to express my strong support for the continued funding and protection of our partner, DC HealthLink, which has played a crucial role in providing affordable health insurance coverage to our residents. The work that DC HealthLink has done to lower premiums and expand coverage has been transformative for our community. However, this progress is at risk due to the expiration of American Rescue Plan, or ARP, and Inflation Reduction Act, IRA, which have provided essential relief for middle-class families and individuals, small businesses seeking affordable healthcare. Under the current system, DC HealthLink has achieved a remarkable coverage rate, with nearly 97% of our residents now insured. The success has been largely driven by the lower premiums made possible by the ARP IRA, which allowed for more than 21.4 million Americans, including tens of thousands in the district, to access affordable private health insurance through the ACA marketplace. The savings for DC residents have been significant. On average, residents save $650 per month on their premiums, with those aged 55 and older saving an impressive $1,052 per month. The impact has been even more profound for those who are most vulnerable. More than 7,300 residents have benefited from lower premiums since 2021, and more than 2,100 residents gained coverage they otherwise could not afford. Some individuals now pay as little as $13 a month for their insurance. In total, district residents have nearly $12 million annually in premium costs. These are savings that directly improve the financial security and well-being of our residents. Unfortunately, these vital gains are at risk of being reversed if Congress does not act. Without the continuation of ARP IRA provisions, premiums will skyrocket. Middle-class families, small businesses who are now eligible for lower premiums for the first time will lose this relief. For residents ages 55 and older, the impact will be especially severe, with premiums set to more than triple. For those with incomes above 400% of the federal poverty level, this will mean a loss of $800 per month in premium savings. In addition to individuals and families, small business owners, self-employed workers, and those employed by companies without group coverage will face premium increases that could make insurance unaffordable. These workers, many of whom are already struggling to make ends meet, will see their costs go up drastically. If Congress allows this relief to expire, thousands of district residents will lose their health insurance. I urge Congress to act now to make the ACA premium relief permanent so that all working families and middle-class Americans can continue to benefit from affordable health insurance. We cannot afford to go backwards. Let's build on the success of DC HealthLink and protect the health and well-being of our residents for years to come. Thank you for this opportunity, and I'm available for questions.
Thank you. Eleni?
Yep. Hi. Yes. Good morning, Chairperson Henderson, members of the Committee on Health and staff. My name is Eleni Reyes, and I serve as both a teacher and assistant to the director at the Institute of Our Lady of Mount Carmel, a child development center dedicated to supporting children ages 2 to 5, located in the Michigan Park neighborhood of Ward 5. I am here today to share my experience and to express my deep gratitude that the DC government has chosen to support the well-being and financial stability of our childcare workforce through the Healthcare for Childcare program. The Squirrely School is sponsored by the Carmelite Sisters, a worldwide congregation of Catholic religious women dedicated to the education of young people. As such, the religious nuns who teach at our school tend to be older, which means they have been historically burdened by high premiums. Making ends meet has been very hard for them, but being able to provide health insurance for our teachers has been an incredibly helpful tool to lighten expenses and to provide meaningful support to the teachers who give so much to the children under our care. Speaking as a teacher, while I try to keep myself as healthy as possible, we're taking care of our very small children who get sick easily. Even when sick, our kids still need to go to school and nothing would stop us from caring for them. And so we're constantly exposed to cold, flu, cough, you name it. This season in particular is very hard, which is why having good health insurance is so important. As a parent myself, healthcare for childcare has also provided me and my family with security. I have a teenager and my husband is self-employed. If we have to pay through his business, we would have to pay so much more. Our family costs are still high, but healthcare for childcare is a big relief. And I can't help but think of all the other people who need this. Perhaps in the future, the program can expand the discount for families and other essential workers. Thank you to DC HealthLink for helping our teachers access this incredible benefit, and thank you for the opportunity to testify today.
Thank you. Marcelina?
Good morning, Councilor Henderson, council members, and the DC community. My name is Marcelina Romero. I am proud to be a Ward 5 resident, my mom of child in a DC pre-K program, and the interim executive director of the Multicultural Spanish-Speaking Provider Association, MSSPA. We advocate for and represent over 1,500 early childhood educators, directors, and owners of child development centers and home-based programs here in DC. Approximately 95% of our members are women, many of whom are working mothers who provide high-quality care and education to our city's youngest residents. Our members are employed across more than 100 licensed early learning programs and several public schools, making a profound impact on the lives of thousands of children and families in our community. MSSPI serves as a vital link between the community and resources, providing health information about health insurance benefits to child development facilities and their staff. Our members are grateful for healthcare for child care program that provides free or low-cost health coverage for early childhood education providers and their families and their teams. MSSPA has served as an outreach partner for the past 2 years. We have hundreds of Spanish sign-ups. This year, we and our partner TCLC will provide health insurance literacy for nearly 2,000 early childhood educators, staff, and their families. Thank you for the opportunity to testify today. As a partner of DC Health Link for over 2 years, we have witnessed firsthand their commitment to listening to the community and striving for excellence. Healthcare for Childcare ensure that these dedicated professionals have access to vital health insurance. This is especially crucial, and many educators rely on healthcare for childcare as their only access to free or low-cost health insurance and affordable healthcare. Healthcare for Childcare has provided our members with financial protection, access to resources, and peace of mind, reducing worries knowing they have coverage. Be sure that when our members have access to quality healthcare, they can provide better education to our children. We are grateful for the opportunity to partner with you to support our early childhood educators. We look forward to continue to work together to expand the Healthcare for Childcare program and increase access to benefits, including oral health coverage. Thank you for your commitment to the well-being of our educators and children. MSSPA, the Multicultural Spanish-Speaking Provider Association, is proud to be part of this effort. Thank you.
Thank you. Dennis?
Good morning, Chairperson Henderson and the members of the committee. My name is Dennis Angel, and I am an in-person assessor at Mary Center, a federally qualified health center with locations across the DC metropolitan area. Mary Center employs 2 in-person assisters who implement the Health Benefit Exchange program. Mary Center and the Health Benefit Exchange Authority have had partnerships for nearly over 12 years. At Mary Center, we witnessed firsthand the impact that the in-person assistance team have in supporting DC residents accessing health insurance providers through the DC Health Link Affordable Care Act health insurance marketplace in DC. During the fiscal year of 2024, our 2 in-person assistants supported more than 2,743 DC residents and their families in obtaining health insurance. We conducted both in-person and virtual outreach events in English and in Spanish to educate our community about the benefits and enrollment process related to health insurance. Our presence in the community extended to evening hours and weekends, and we host various indoors and outdoors events. Our strategic approach for the year 2024 focused on participating in as many outreach enrollment events as possible to reduce the number of uninsured residents in Washington, D.C. In collaboration with the communications and marketing teams of DC Health Benefit Exchange Authority, we participated in a total of 17 outreach events. Additionally, we engaged in 21 hybrid one-touch enrollment sessions, which took place at Carlos Rosario Public Charter School in our virtual platform. Mary Center's IPA team also conducted outreach activities with Brea Public Charter School, attending 14 enrollment events in total. In addition, in assisting consumers at Mary Center in participating in outreach efforts, our insurance program assisters contributed to the organization's quarterly orientation sessions. These sessions are designed for all Mary Center employees to serve the community with the goals in connecting individuals into public benefits. During these sessions, our entitlement managers provide valuable information and answer questions about health insurance enrollment through the Affordable ACA. Our commitment to maximize opportunities for the uninsured DC residents to enroll in health insurance reflects the Mary Center's Health Benefit Exchange program dedication to ensuring high percentage of residents obtaining coverage. The residents of Washington, D.C. consistently express their heartfelt appreciation to our culturally specific services, which are delivered in their native languages. These vital services significantly enhance health insurance literacy and empowerment individuals to enroll in qualified health plans. We are profoundly grateful for the partnership of leadership of the DC Health Exchange. The dedication and training and supporting our staff have proven invaluable, enabling us to serve our community more effectively. Additionally, their experience in identifying and organizing outreach events has been instrumental in reaching those who remain uninsured. Thank you for granting me the opportunity to testify, and I am eager to answer any questions that you may have.
Thank you, Dennis. Ms. Davis. Janice, if you're speaking, you're on mute. Ms. Davis.
Can you hear me?
Yes, I can hear you now.
Okay, great. Good morning.
Good morning.
As a fourth generation DC resident, a 30-year insurance broker, and a DC business owner in Ward 4, I am pleased to speak with you today. My name is Janice Haynes Davis, and I'm a licensed broker serving DC, Maryland, Virginia, and several other states. I would like to also commend DC HealthLink because in all these 3 states, basically I call DC a state, we actually offer small employers and individuals greater choice. I would also like to commend DC HealthLink and BISB for the annual public rate hearings and their efforts to make plans more affordable. This arena has given us an opportunity to understand the process as well as a voice to our concerns. Rates were a bit better this year. I'm going to tell you a little bit about something you probably don't know about DC HealthLink. In addition to managing the routine tasks of managing the daily workings of HealthLink, and these are never routine, HealthLink has embarked on the ambitious task to address some of the health inequities within our community. I am pleased to be a part of the working group on social justice and health disparities. Initiated in 2021, this group of stakeholders, carriers, universities, and DC agencies have worked together to identify those chronic illnesses and social and racial determinants that disproportionately affect our communities of color and underserved populations. We have focused on plan design, access, costs, and other barriers that contribute to these disparities. We identified and acknowledged those social determinants of health inequity, including housing, environmental conditions, and food insecurity as contributing factors. Over the past few years since 2021, this working group has identified those chronic health conditions that we felt we could make the most positive impact. Based on qualitative and data and research, we sought solutions. These conditions include heart disease, hypertension, diabetes, child mental and behavioral health, diabetes, and HIV and AIDS, which we worked on last year. When faced with an expanding HIV/AIDS population, the highest in the country, we sought answers. You will be able to see these recommendations as evidenced in your plans that will be launched again in 2026. Several changes were adopted in 2022, 23, and 24 for the following years. Consumers will see the difference in equity-based plans designs in order to eliminate some of the barriers. The board proposed lower cost sharing. That means the co-pays that you pay when you go see the doctor. For physician services, lower cost, and in some instances, no cost prescription drugs. Carriers worked in cooperation and in accordance with actuarial standards to implement these changes. Plans now have lower co-pays and deductibles. These substantive changes are designed to target those diseases that impact our most vulnerable populations. In my written testimony, you'll see an example of what we did last year and the year before, and especially those that had to deal with child and adolescent mental health problems, which really arose and caused a basic during the pandemic. There was such a substantial increase in this incident of mental and behavioral problems in our city's youngest population. We thought that this was the problem that needed to be addressed at that time. In today's ever-changing, regressive environment, DC HealthLink conforms to the Affordable Care Act.
Ms. Davis.
There's hope that we all can continue to meet our challenges.
Ms. Davis, if you could, you're a little over your time.
Okay, I finished.
Oh, that was it. All right, great. Thank you.
I said it is hope that we all can continue to meet our challenges.
Okay, great.
And you'll see examples of the plan designs and everything in the paper. It's a little technical, but you'll see them when you see 0 copays and expanded office visits and no copay.
All right. Well, thank you so much. Hold on, because I'm going to have some follow-up questions for you.
Okay.
I want to thank all of this panel of witnesses. I know always we can get to a little bit later in the hearing. It's a little difficult when we're talking about some of the similar things, but for all of you who are talking about healthcare for childcare, I hear you. As well as thank you to the Restaurant Association and the Greater Washington Hispanic Chamber of Commerce for talking about the impact of working with HBX in terms of small businesses. Dennis, if you're here still.
I'm here.
Great. I wanted to ask you a couple of questions, given your role as an in-person assister at Mary Center. One of the things that we sort of talked about is that how important outreach can be. I'm wondering from your experience, what type of outreach is most successful in terms of communicating with the constituents you all serve?
Any part that you're dealing with people in person or something that's more out gauging is usually more beneficial because people hear from word of mouth or they hear from the information that you have to provide for them. So anything that is more in person is definitely more beneficial. We like I said, we do virtual enrollments as well. But those are just more for enrolling people. But in order for us to get the information across, I personally find that more of an in-person will be a lot more beneficial for them.
Yeah. And I agree that in person, sort of having that conversation with folks is super, super important. Did you all get any additional training last year in terms of the special enrollment period and some of the other things?
Yes, we did.
Okay. And going into 2025, I guess speaking for yourself, but also some of the other in-person assisters that you talk to, what additional support do you think you need to help you all, one, broaden your reach, and then also meet the goals that you all have laid out?
Well, first of all, I think it's the training is mostly important. We do a yearly training that we do. DC HealthLink has definitely provided us with the resources. They also provide us with just stuff just to give out in order to people like for example like flyers. They have little cool hats with DC HealthLink, and just anything that will catch just people's attentions is definitely helpful.
Okay. All right. Ms. Davis, I wanted to follow up with you. In your testimony, you talked a lot about some of the good things that we were doing here in the district, but if you had to name, one or two things that you wish that we would take up to help improve healthcare access, particularly for those who are small business owners, what would that be?
Lower premiums. And the other thing is, that's the big thing. It's just these double digit. I had a client who had a 20% rate increase, and of course, no one can survive, especially in small business. And people are being able to make choices between, giving salary increases, raising deductibles, et cetera. That's the number one. The other thing is that in other jurisdictions, they do something called composite rating. And as a senior citizen myself, as everyone knows, basically ACA is age banded, which means that those people who are older pay higher premiums. It's great because, no sexual barriers and no pre-existing. But it puts a burden on the employer because, in fact, when he's looking at a 20-year-old and he's looking at a 65-year-old experienced person, then in fact, which one do you choose? Well, you want to choose the 65-year-old, but the 20-year-old's premium is $200 and the 65-year-old's premium is $700. So because we adhere to age banding in the district, and DC HealthLink really does not allow what we call something called composite rating, which is average age, which you all probably have at your office, because if you're a single person, you pay the same rate no matter what age you are. So if we could figure out some way We could do some composite rating, which would share the age burden, which of course is not a burden. It would be great if we could include that. But in terms of transparency, the tools and everything, they have greatly enhanced them, much more consumer friendly, and employees can really understand what their premiums are. But again, those are the two things, especially when I compare the regions, but the rates are just ridiculous. You know, they really are.
Yeah, well, I mean, you know, Ms. Davis, you know better than everyone, right? The rates are ridiculous everywhere.
I know they are.
And you know, that's a larger question. Some above our payroll, but we're gonna work through what we can here. But thank you so much to all of the witnesses who have testified. And Ms. Davis, we'll look into what you talked about a little bit more.
Yeah.
And see what relief, if anything,
Yeah.
that we could try to provide in this kind of very weird climate that we're in.
It is.
But
I think, and I think just in terms of just from my background, I've not worked with a group of people who were so concentrated on the District of Columbia, and really this whole study on racial inequity really is very revealing about where we need to put our dollars as well. So it would be something if in fact people could take a look at it, because you see all of the other forces that come into play, but you know, they should be very aware. I mean, even in terms of the HIV crisis that we're having, most people are not aware that we're #1 in the nation. So we should take a look at some of those studies more. And I'm happy to be involved in that.
great, thank you so much. All right, we're gonna go to our last panel specifically for HBX, and then we have 3 public witnesses for the Food Policy Council. I'm just forecasting where we're gonna go because it is a little before 11 o'clock. After we finish all of the public witnesses, we're gonna take a 10-minute break so that we can drink our water, stretch, etc. And then when we come back, then we're going to do the executive director of the Health Benefit Exchange, and then we'll do the food policy director for the Food Policy Council, Caroline. All right, so our final panel, Yasmina Castellanos, Heather Duncan, Rosemary Martinez-Nix, Dorothy Council, and that's it, because I have Rosemary here twice, so. All right. Again, if you're joining us, you have to affirmatively accept our invite to become a panelist. I do see Yasmina, so why don't you go ahead and get started? Yasmina, if you're speaking, you're on mute. It's my favorite part of Zoom. If you're speaking, you're on mute.
Let's see here. There it is. Greetings, Chairperson Henderson and members of the Committee on Health. Can you hear me now?
Yes, I can hear you now.
Okay, wonderful. Thank you. Thank you for the opportunity to testify today. Again, my name is Yasmina, and I represent the partnership between Community of Hope and the great partnership we have with DC HealthLink. And just to give you an idea, I oversee 3 of our sisters across our sites, and we have been in a sister organization for over a decade. Our enrollment assisters support enrollment and outreach efforts to ensure that our DC residents are able to enroll in coverage in person, via telehealth, and or over the phone. Our partnership with DC HealthLink allows us to support the community while also providing healthcare. It's a great combination. We have clinics in 3 quadrants of the city: Northwest, Northeast, and Southwest in wards 1, 5, 8, and are proud to say we connect with neighbors, friends, and small businesses. As many of us may know, navigating our health system is not easy, and our enrollment assisters are an important support for residents. We witness the direct positive and positive impact on our community on an everyday basis. During the Medicaid unwinding phase, we met a patient who had lost Medicaid coverage due to a change in income. And when she came to us, she was dismayed and disheartened. She was already experiencing financial hardship, and the prospect of needing to pay for health insurance was very overwhelming to her. We found that through the ADAP program, she had the option to have the entirety of her health insurance premiums paid. She has multiple chronic health conditions, and ADAPT's assistance gave her that option to enroll in a platinum health plan with 0 deductible. We were also able to get ADAPT to expedite her enrollment so that she could start her new insurance without needing to pay any month's premium. She's been enrolled for almost a year and completed her recent renewal process to stay enrolled in coverage. Now that DC HealthLink has essential plans that include cardiovascular disease care, she can get her imaging for free. Wherever she visits now, whenever she visits us, she's very enthusiastic and confident about her health insurance coverage. This is just one example of how our sisters work to support DC residents in accessing affordable health care coverage. There are also many circumstances when we're able to support residents access other health insurance coverage they may qualify for. For example, one of our sisters encountered a patient who was uninsured with a recent cancer diagnosis. We completed her district direct Medicaid application and worked with her doctor to provide a supporting documentation for her case to get expedited. And along with the Medicaid renewal team, her insurance was approved within the same week. The patient received the oncology treatment and continues follow-up care. As a sisters, we are always working to enroll residents through DC HealthLink, but we are also able to help patients enroll in any other program they may qualify. To this end, we're all working to reduce uninsured rates in DC and improve healthcare access for everyone. Our cases are numerous. However, there are some that stay with us because we wonder, had this patient not found the help in a timely manner, would they have given up hope? So our partnership with DC HealthLink allows for DC residents to have options, resources, support, and direction as they navigate a complicated healthcare system. This directly contributes to their well-being and their health, and together we've made a difference in the lives of many DC residents, and I thank the committee for its continued support of our work. Thank you very much.
Thank you. Heather?
Good afternoon, Chairwoman Henderson and members of the DC Council. My name is Heather Duncan, and I am an educator and child care worker based in Washington, DC. I work at Capitol Hill Learning Group, a child care facility where I have dedicated my career to supporting district families and the development of young minds. I am here today to voice my strong support for DC's Health Care for Child Care, a program that has profoundly impacted my life and the lives of many in my community. Child care workers are the backbone of early childhood education, shaping the lives of our youngest learners and laying the foundation for their future success. Research shows that children who attend high-quality early childhood education programs are 25% more likely to graduate high school and 4 times more likely to earn a bachelor's degree. Yet, despite the critical nature of our work, many educators and child care workers face low wages and limited access to essential benefits like healthcare. This was my reality just a few years ago. As a mother of 3 teenage children, the rising cost of living in DC placed immense pressure on my family. I was at a crossroads, seriously considering leaving education, a field I love and believe in deeply, for a job that could provide better financial and healthcare security. Then healthcare for childcare became available, and it changed everything for my family. This program provided my family with access to premium healthcare while allowing me to stay in my job, a job that I am passionate about and believe in. Over the last 2 years, it has been a lifeline for my family. With healthcare, through this initiative, I no longer have to choose between my family's well-being and my career. It made it possible for us to survive and even thrive in these challenging economic times. At Capitol Hill Learning Group, we have experienced firsthand the transformative effects of DC's progressive programs like Healthcare for Childcare, combined with other innovative initiatives such as the Early Childhood Educator Pay Equity Fund, the DC Lead. These programs have enabled our preschool department to achieve 0 teacher turnover for 3 years. This is remarkable. This stability is rare in our field, where turnover rates often exceed 30% annually, but in DC it's much higher because of our transient population. Low teacher turnover has had profound benefits on our community. It has helped build trust with families. It strengthens relationships between parents and teachers and establishes consistency for our children. When children see the same educators year after year, it fosters a sense of security and continuity that is essential for their development. Because of these progressive programs, you have made it possible for families to thrive in the district. The benefits of this program extend beyond individuals like me and my workplace. I urge DC Council to continue funding and expanding the Healthcare for Childcare incentive. This program is a testament to the district's commitment to its educators, workers, children, and families. By supporting this initiative, you are investing in the people who invest in our future every day. Thank you for your time and attention to this matter. I'm grateful for this opportunity to share my story and advocate for a program that has made such a meaningful impact on my life. Thank you.
Thank you so much, Ms. Duncan. I don't see Ms. Martinez next, nor Ms. Council, but we did have two people who were left off the list. Carlos?
I'm here. Thank you so much.
Go
Can I
ahead.
go? All right, awesome. Good morning, Councilmember Henderson. Thank you so much for your continued work and for this opportunity to testify. My name is Carlos Duque, and I'm the director of Amazing Life Games Preschool. We're a nature-based and play-based preschool here in DC. We probably participate in both the Pay Equity Fund and Healthcare for Childcare. And I'm here today to urge the council to continue and expand these critical programs. So at ALG, we've always prioritized providing healthcare for our educators. And thanks to these initiatives, we've been able to keep tuition increases low while offering competitive wages. While many independent schools in DC last year raised tuition by like 10 to up to 14%, our increase was only 4%. Additionally, we were able to triple the amount of scholarship funds we offer, helping us remain accessible to families while continuing to invest in the well-being of our teachers. This program is working. This allows small schools like ours to offer quality early child education without placing additional financial burdens on families. I strongly encourage the council to sustain and grow these efforts to ensure that all early childhood educators receive pay and benefits that they deserve. And so opening this up or getting rid of the wait list whenever possible would be really awesome for everyone. I also want to add that it's hard to overstate the relief that teachers, families, and I feel knowing that our educators have access to healthcare. Because of these programs, our teachers can see their healthcare providers, get the care they need, and prevent the spread of illness. And like so many educators have talked about, this flu season is, intense. This is really awesome to know. Families want to know that their children are coming to schools where their teachers are being taken care of. And I love to know that as well. This will not only keep our community healthier, but also allow teachers to return to work sooner than if they lacked healthcare or had to delay the treatment due to cost. I'm open to any questions, but thank you so much for this opportunity.
Thank you. Max?
Yeah. Hi, my name is Max Broad. You may know me from my work as the Executive Director of DC Voters for Animals. Today I'm testifying from the perspective of just a small business in DC who relies on coverage from the ACA marketplace through DC HealthLink. As confusing as healthcare can be, I appreciate all that DC HealthLink has done to help me make informed decisions on my healthcare needs. Being a nonprofit employee who has a pre-existing condition, I've been surprised to see my medical expenses rise significantly. My premium payment almost rivals my rent. This makes me think of all the nonprofit leaders who also rely on the marketplace for healthcare services. I'm privileged to be able to come here and testify, but there are a lot of people who don't have the time or ability to do that. And the Department of Insurance, Securities, and Banking sets marketplace insurance rates in the district. And one opportunity to better support residents who rely on ACA coverage would be to coordinate with the Committee on Business and Economic Development, chaired by Councilmember McDuffie, to assess if there are ways to improve the long-term affordability of health insurance plans offered through the marketplace. We have a very strong mechanism to make plans accessible to residents, and now is the time to ensure that those plans are affordable for everyone, especially those who are working to keep their nonprofit organizations and small businesses located in DC. A reliable, accessible, and affordable healthcare exchange is critical to those of us who dedicate our time to our community and our city. Without the Affordable Care Act and DC HealthLink, I know that my health insurance options would be completely unaffordable or worse, non-existent. I encourage DC's vigilance, as attacks on healthcare and the ACA marketplace can undermine the ability of our vulnerable low and middle class residents in the city. With threats against our immigrant community already underway, political divide over federal ACA subsidies, and the recent freeze on essential federal grants, the council's support and protection over our local affairs has never been more critical. Thank you for hearing my perspective.
Thank you. And thank you to all of the witnesses who provided testimony. Again, Ms. Duncan and Ms. Castellanos, thank you so much for being here and talking about specifically how these programs have helped. And Mr. Broad, as a business owner, Mr. Duque, also because you run a preschool as well. We've got lots of questions for the Health Benefit Exchange Authority, so we're going to get to those momentarily. I am now going to call the witnesses for the Food Policy Council. I have three here: Delia Bachland, Claire Hyson, and Jaren Hill Lockridge. If those folks can join us in. I just want to say for the record, for folks who don't know what the Food Policy Council is. So the Food Policy Council and Director Establishment Act of 2014 established the DC Food Policy Council to promote healthy food access, sustainability, and the local food economy here in the District of Columbia. The Food Policy Council in particular consists of 12 public members appointed by the mayor and approved by the council, and 10 ex officio members representing district agencies. The law requires the Food Policy Council to hold at least 6 public meetings per year and create various working groups to tackle some of the priority issues. They also have to submit an annual report to the mayor and the council, which this is not Caroline's fault, but the report is late, if anyone on the executive is listening. And also outlining some of the local food economy and food access issues across the district. The committee did send written pre-hearing questions to the Food Policy Council. Again, those are available on the council website if you're interested. And we'll get to Caroline Howe, who is the executive director, momentarily. But first, the public witnesses. Okay, I only see Jaren. She might be the only one here for right now. All right, Jaren, when you're ready.
Good morning, Chairman Henderson and members of the Committee on Health, residents of the district. Thank you guys for the opportunity to testify today. I'm Jaren Hill Lockridge, and I'm testifying as the Director of Strategic Partnerships for Dreaming Out Loud. We're an organization dedicated to advancing food justice, economic empowerment, and community self-determination here in DC. Today, I want to emphasize the critical role that policy plays in shaping food access and health outcomes, particularly east of the river. Too often, conversations around food access in Wards 7 and 8 use the terms food desert. And that's a term that implies a natural occurrence rather than the result of deliberate policy choices and systemic inequities. Instead, I urge us to use the term food apartheid, and that more accurately describes the structural barriers that create and sustain unequal food access, particularly in our community. And using this language shifts the responsibility from the individuals and the communities to the systems that actually make healthy food difficult to access. And it underscores the need for policy interventions that address these systemic failures. Recognizing the urgency of these issues, a few of us took it upon ourselves to gather groups that are focused on building food justice, particularly east of the river. Our coalition of grassroots organizations, community leaders, and food justice advocates have worked to address and find solutions to what's going on. And through collective action, we're trying to advance initiatives that, of course, promote urban agriculture, our community-based food distribution, and other cooperative food grocery models that keep the resources circulating within our community. One big example that I want to raise, and thank you, Chairman Henderson, for bringing it to our attention recently, is like the supermarket tax credit incentive that was encouraging grocery store development or market development west of the river versus east of the river. While the program is intended to support grocery stores in certain communities, we know that this has primarily benefited those on the other side where grocery and food access is already robust. Here in Ward 8, where we have some of the highest rates of food insecurity and diet-related chronic illnesses, this just don't make a lot of sense. It really doesn't make sense. And we want to raise this and see what we can do about it. If we're serious about achieving food equity in DC, particularly east of the river, we got to reevaluate and redesign some of these policies to just make it make more sense. And we also have to integrate food policy and health policy around like food is medicine to ensure that our folks that need it the most, are getting access to what we need. Again, I appreciate the time and the space, and I urge you guys to, come check out the Marionberry Avenue Market whenever you get a chance. And thank you again for your time, your commitment, and your support. And I welcome any questions that you have.
Thanks, Sharon. Since you're the only public witness and I'm the only council member here, I'll ask you some questions. I wanted to, well, first, thank you for being here and for your testimony and for the work that you continuously do on behalf of, your neighbors in the Great Ward 8 around food access and sustainability, not just with Dreaming Out Loud, but before that and all the work that you did prior to then. I'm curious, as Dreaming Out Loud is doing the work of, trying to establish this new market on Marionberry Avenue, have you all interacted with the Food Policy Council in your work, or what conversations, if any, have you had with other parts of DC government around being able to support what is essentially like a non-traditional format for a market space?
Great question. So Chris Bradshaw, our executive director and founder, was a part of the Food Policy Council. I don't think he currently still sits on the council, but I do know that he was intricately involved in its early formations in a couple of years back. The Food Policy Council, I believe Caroline has been here on a tour. I believe she has. If she hasn't, I'm sure when she comes on, she'll be like, yeah, I have. But the invitation is always open, and we welcome them to come over and see what's going on. Yeah, that's why I'll stop there.
Okay. You know what I thought was interesting in terms of your comments, right? So when it's my encouragement to folks, please look at the pre-hearing questions and responses, because we ask these questions to try to get a basis of, sometimes it's data, sometimes it's other reports and information, for us to have more fruitful and non-basic conversations when, the government witnesses come up here. And this sort of stat kind of jumped off the page to me when I was sort of reviewing all of this information, is that DC has had 20 new grocery stores open in the past 5 years. But when we look at where, that's a wild stat. That we've had 20 new grocery stores open across the city, and yet none of them have been east of the Anacostia River. Well, that's a lie. One of them. Right at Skyline. In terms of the conversations that neighbors are having, you said, let's refer to this as a food apartheid, as opposed to just a food desert situation. I think that's interesting in sort of underscoring that none of this is by chance, but it is by design and policy.
Correct.
Okay.
Correct. You are correct. And let's, if we can, let's talk about like food desert versus food apartheid because it is systemic. This is not by chance. This is by design. And you know, when people say the word food desert in conversation with us, it's hard stop. A desert is a naturally occurring place. We live in the nation's capital, right? The greatest city on earth. If ambassadors can get food from wherever they're from to people, why can't we here, residents of the capital city, eat healthy food? It just doesn't make sense. But we also recognize that we're resilient and resistant people, and people in our community have been eating and finding ways to eat regardless of what the systems have done. And we want to raise those people who are doing the work, the boots on the ground, who are connecting the dots without the incentives and the government-backed resources and support. Their mothers and, you know, grandmas and fathers and parents, like people in our community have been eating anyway, and we do the work anyway. So food apartheid shifts that responsibility from the individuals making the choices to the systems that make it difficult for us to access food. And that's what we want to raise and begin to address by connecting the dots around the vertical integration of what it means for us to be able to feed ourselves. So there is work that's being done in community. It's just not rising to the level that, you know, a lot of people are hearing and seeing about.
Yeah. Well, I mean, I think you made an excellent point in terms of, you know, folks finding a way, whether it be growing their own or um, using the farmer market system or, you know, driving to Maryland or doing sort of these very, I think, you know, when you folks don't have a lot of time on their hands, they don't have time really to go to 6 different places to just buy the basic groceries that you need for the week, right? That's a lovely idea. We'd love to have that European sense of let me go to the market every day, right? And so folks want to go one place and be able to do that. I know you and I could talk about this all day. Truly. I've got some questions for the Food Policy Council in terms of their work and also what connections they're having with other government entities to uplift these conversations around some of these things, right? Like there are lots of ex officio members who are part of DC government who are part of the Food Policy Council, and yet we don't necessarily see some of the policies getting to the places where they need for action. But thank you, Jaren, for being here and for the work that you do. As I mentioned before, we're going to take a 10-minute break. It is 11:18 now, so around 11:28, we'll come back and we will start with Mila Kaufman, who's the Executive Director of the DC Health Benefit Exchange Authority. So we'll be back in 10 minutes. Thank you. All right, and we are back. As I mentioned before our little break, we now have before us Mila Kaufman, who's the Executive Director of HBX, who's going to provide testimony to the committee. Mila, before you begin, I got to ask that you or any members of your team who might testify have to swear you in. So if you raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Great. All right. If you turn on your mic, and then you can get started.
Thank you very much. And I think it's good morning still, maybe good afternoon. Chairperson Henderson and members of the Health Committee, it's a pleasure to be here with you. And with me, I have members of my team who I may call upon during question and answer to provide you with additional detail. Thank you once again for having us. I'm the Executive Director of the Health Benefit Exchange Authority, and I'm going to ask my CIO to help advance these slides since they're frozen. Perfect. Thank you very much. First, I'm just going to give you a little bit of a background about us. I'll touch upon the federal landscape and the Inflation Reduction Act, our open enrollment, our implementation of Expanding Access to Fertility Treatment Amendment Act of 2023, healthcare for childcare, and our social justice and health equity work. So as a way of background, DC HealthLink is the ACA state-based online health insurance marketplace here in DC, and we're responsible for it. We were the last to start our IT build back in 2013, and we were one of 4 state-based marketplaces that opened for business on time on October 1, 2013. We are funded through an assessment on health carriers, and just last year, we celebrated a very successful 10 years. We are near universal coverage here in DC, thanks to our efforts and the Affordable Care Act. More than 97% of residents have coverage. And since we opened for business, we've helped cut the uninsured rate by half. We rank number 2 in the nation for the lowest uninsured rate. We cover nearly 100,000 people with private health insurance, and that includes more than 5,300 district small businesses and nonprofits. We work with more than 900 brokers that provide free help to our customers, and we're responsible for more than $670 million in annual premiums. The Inflation Reduction Act was a game changer. It helped lower premiums for more than 24 million people across the nation, including here in DC, and for the first time made middle-class families eligible for lower premiums. Middle-class families, self-employed, and small business owners who buy coverage on their own have lower premiums now. And if Congress takes this away, expect huge premium hikes and millions of people to lose their health insurance coverage. Here, our premiums are as low as $13 a month. 68% of people with lower premiums in DC are self-employed or small business owners who buy coverage on their own. 1 in 4 residents covered on DC HealthLink's individual and family marketplace gets lower monthly premiums, and residents save on average $724 a month. A little bit about our open enrollment. We're still in open enrollment. In fact, residents have until Friday, January 31st, to get enrolled. We have 27 different options from Care First, Blue Cross Blue Shield, and Kaiser Permanente. We have essential plans that have no deductibles for primary care, specialists, mental health, and urgent care, as well as generic prescription drugs. These plans, these essential plans, also provide no cost sharing for certain conditions like type 2 diabetes care, including insulin, $5 copays for outpatient pediatric mental health care. And new for this year, we have no cost sharing for heart disease, high blood pressure, and stroke. And all of our DC HealthLink plans now cover fertility treatment, which is a benefit expansion that you, council member, led. And it is now in effect for all DC HealthLink plans. A little bit about our implementation of that new benefit. We worked very closely with DISB. And recently we received great news from the federal government. We've updated our essential health benefits benchmark plan, and it's been approved. So that means the district will no longer have to defray the cost of this new benefit starting plan year 2026. You heard from some of the public witnesses about some of our special enrollment periods. I want to highlight for you one special enrollment period that we adopted earlier this year, and that is to make DACA status people, dreamers, essentially, eligible for health insurance coverage with lower premiums through DC HealthLink. A quick update about healthcare for childcare. The program currently has 1,967 people enrolled. It covers 220 facilities, and that is 8 out of 10 eligible facilities are currently enrolled. And since we started Healthcare for Childcare back in January of 2023, Healthcare for Childcare has helped 2,414 people in 231 facilities. For FY25, we have $12 million for Healthcare for Childcare. And that helps to ensure that workers, dependents, and facilities currently covered can stay covered and won't lose their health care for childcare health insurance. It also ensures that workers and their dependents who are DC residents can continue to enroll in health care for childcare individual and family plans. We did institute a wait list. We developed the policy this past fall. We had input from OSCE as well as extensive input from our Healthcare for Childcare Advisory Council. And currently we have no facilities on the wait list. The wait list became effective January 1. Quick update on our social justice and health equity work. As you heard from some of the public witnesses, we've been engaged in equity work since 2021. One of the areas we focused on is moving our coverage to becoming equity-based benefit design. We know that disproportionately communities of color in DC report, compared to white residents, report cost as being a barrier to seeing a doctor. So one way to address that is to remove cost barriers that prevent people from getting the care they need. So starting in 2021, we started to change our benefits. We added type 2 diabetes, took away deductibles, copays, and coinsurance for outpatient care for type 2 diabetes. And as I mentioned earlier, that includes free insulin. It includes your annual foot and eye exams, lab work, and seeing your primary care physician. New for this year, heart disease, high blood pressure, and stroke. We've removed cost barriers for outpatient care for those conditions. That includes include CT scans, which could be as much as $500. Now it's no cost to the patient. And pediatric mental health, we lower to $5. We believe these design features will help save lives. In addition, we finalized our benefit design for 2026 plan year, and we removed cost barriers for HIV care. And that includes visits to family medicine and internal medicine doctors, generic prescription medication, and lab works. So no co-pays, no co-insurance, and no deductibles. I want to share some data which shocked me. Apparently, approximately 71% of people living with HIV in DC are Black and 8% are Latino. So this benefit design, which we finalized to become effective in 2026, will definitely help get care to people who need it and will help save lives. A quick note about our other work on equity. It's not only benefit design that matters, but clinical guidelines. And certain clinical guidelines continue to have race and other bias embedded. The good news is some guidelines have been updated to remove race. One of them we've been working on is called EGFR, which is the kidney function test. The reason I keep talking about this is because even though the clinical guideline has been updated, so it's now race neutral, it's no longer recommended that if you're Black and you get EGFR, that extra points get added to your score to make your kidneys look better than they actually function. That's the good news, but the reason I want to keep talking about it is because not all labs have updated their calculation, and many labs around the nation continue to use the old test, which of course matters because kidney patients get the wrong dosing, sometimes don't even get put on the transplant list, don't get benefits, disability benefits, and others that they're entitled to. So it's really important for all labs to update their EGFR calculation. We've been devoting significant resources to understanding why that hasn't happened. And we care about this because not only do we cover DC residents, people who live here, but we have more than 5,300 employers here in DC with workers everywhere who live in other states where some labs are still using the old tests. So we'll continue to work on that, and I'll continue to provide you with updates on our progress. And I see I'm out of time. Okay, thank you for a few more minutes on this. Just to focus on the EGFR efforts that we're engaged in, one of our next steps to help push labs to change the calculation that they use is to partner with large purchasers of benefits. So large employers could require their network providers, their labs, to use currently recommended race-neutral EGFR. When there is a push to use the most current clinical guidelines, then providers of those services will respond. So our next step is to work with large purchasers and to get large purchasers to build this requirement into their networks. I want to say that open enrollment for DC is still in effect January 31st. I encourage every resident who needs coverage to enroll before January 31st. Otherwise, most will have to wait until the next open enrollment, which does not start until November 1st. And And again, I just want to appreciate all the partners we have. You've heard from many of them. Without the full support of our partners, we would not have the successful record we have. And also just acknowledge my entire team. You've heard some of them mentioned by name through the public witnesses. It's always gratifying to get recognized and get a shout out in that way. It's very motivating and nourishing to our entire team. And I certainly appreciate their public service every day and the assistance they provide. And with that, I'm happy to take any questions you may have.
Thank you so much, Mila. I did a podcast with one of my colleagues last week, Councilmember Parker, he's a member of this committee, but also the council member from Ward 5. We talked about performance oversight. And I said, I think this is actually one of my favorite times of year because I literally learn something new every day. And I feel like this is an excellent opportunity for us to sort of dig in on agencies such as yours that may not get the quote unquote daily shine, if you will, but are doing some of the very good work around ensuring that DC residents are staying healthy and are, able to receive care, if you will. So I do have some questions. I want to follow up on some things. I actually want to start with some questions about equity and access piece. And I think this is super important. Anytime that I'm talking to folks across the district and I tell them like, no, DC, health insurance coverage is not our issue, right? I mean, it's a issue, but it's not the issue. It's hard for them to sort of grasp, oh, wow, 97% of our folks have coverage. But then when you look at our health outcomes data, you do see these sort of very wide disparities. And so I appreciate that you all and your, I don't know if I refer to it as your board or your council, I think it's the board, but that the board has had a very specific mandate and goal, if you will, to try to address some of these equity and access issues as best you can to address some of these disparities. I want to follow up on a particular one that was new last year, or we started the discussion, I guess it was last year or the year before, which was around pediatric mental health. And I think it's a $5 copay is the thing. But one of the issues that we heard from families was that some providers were instituting a facility fee to sort of, so yes, it's a $5 copay, but now I'm going to charge you $25 for the facility fee. Have you all investigated and looked at this, or maybe even sort of talking to DSB about some of the providers who are doing this? Because in my opinion, it defeats the purpose of, if you have a $5 copay, if you're going to add this additional assessment on the back end.
Yes, thank you for raising that. We've also been very concerned. We continue to work with our DSB partners on this. It's market wide. It's not just for DC HealthLink. The idea that certain providers in their negotiation with the health plans build in a facility fee. So it's not unique to DC HealthLink. It's a market-wide problem. So I agree with your characterization of that. We also continue to work with our health plans. It's clear with some health plans whether a facility fee is charged. With others, it's still not so clear reading summaries. And so we continue to work on that issue. It's still an outstanding issue for us.
Okay.
And if I can just add on the equity work, thank you for acknowledging the vision that our Health Benefit Exchange Board has around health disparities and differences in health outcome, and the importance of addressing and getting us to equity, to making sure that everyone has good outcomes, and that the outcome doesn't depend on your skin color or ethnicity or other factors. We did not always focus on this. It wasn't until 2021 that our focus has shifted. We, from day one, focused on getting people covered. And that was our only mission, get you covered. And it wasn't until we saw the pandemic data coming out, who was being hospitalized and who was dying, which was directly linked to race, ethnicity, and other factors. And also when we saw the murder of George Floyd. So that was a pause moment, and that's when our board established our social justice working group. I think you heard from a couple of the members of the working group earlier, to look at how we can make a difference. We're not going to make a difference in social determinants of health or political determinants of health, like food security or housing security, environmental factors. But we do have responsibility and an authority to do something about how commercial insurance, how private health insurance works for our enrollees. And so that was the focus. And through that work of the Social Justice Working Group, we learned a lot, not only about financial barriers to actually getting care, but also bias that exists that impacts how a physician treats per patient. Clinical guidelines that continue to have bias in them and result in worst outcomes. So I just wanted to make sure that it was clear that this issue is very complicated, requires different solutions to address it, and we're fully committed to continuing this work. And I'm also excited that other state-based marketplaces have looked at us as a model and implemented changes in their benefit structure.
All right, I'm so sorry, Mila. We're gonna have to take a break. There is an active fire alarm going off in the building, so everyone has to exit.
Okay.
So, hold on one sec. We need to take a break for a minute to figure out what's going on. Hold on. Okay, we are back. For those who are watching, apologies for that. We did have the fire alarm go off here in the Wilson building, and so we all needed to leave the building, but we have received an all clear from FEMS. Shout out to FEMS for their very quick response to, check things out and make sure everything was going okay. All right. Where were we? We were talking about benefit design. Mila?
Thank you so much. Thank you so much, council member. Yes, so just to highlight our benefit design, our equity-based benefit design, other states, other state-based marketplaces are looking at what we've done. And it's exciting because both the Maryland Exchange and the New York Exchange took our benefit design for type 2 diabetes. And so we're excited about this work. We're fully committed to continuing on this path to make sure that we do what we can, working with our health plans and others in the community and around the nation to help address differences in health outcomes to get us all to health equity.
On that front, you had a slide in your presentation that listed a number of oh, hold on. I took a picture because I thought it was a really interesting document that of the clinical diagnostic tools that use race adjustment, which is kind of interesting in this whole conversation that we're having. Actually, it's not a conversation. It's like one-sided lecture on one side around DEI or diversity, equity, inclusion, and this about face that a lot of folks are making. But in the health space, you have to talk about some of these issues because of they have very real consequences on the other side if you're not considering it. So, the EGFR, the kidney screening tool that you're talking about, I think there was a piece about this in 60 Minutes or something like that that was sort of talking about this a couple of years ago being a particular issue.
Mm-hmm.
How does no, and you all have worked through a couple of things, right? Type 2 diabetes, pediatric mental health, now dealing with this. Can you talk a little bit about how you all are prioritizing working through some of these various issues?
Mm-hmm. So the best way to describe it is we have different work streams because the problem of differences in health outcomes, the contributing factors, it's complex. There's no one solution to say, let's do this, and then we get to good outcomes for everyone. That's not, unfortunately, it's not that easy. So we have to have different pathways to address the different aspects of this problem. Our equity-based benefit design seeks to address financial barriers to medical care. And that's all it addresses. Equity-based benefit design does not and is not designed to address clinical guidelines that have a bias built in that drives and directly contributes to differences in health outcomes. That's why we have a separate initiative. Mm-hmm. Recognizing that we need a different way to address the bias in clinical guidelines, and so for kidney function test EGFR, some of the things we're doing includes figuring out why is it that labs haven't changed, right? And it's because some labs don't know that there's a new updated race neutral guide. Exactly.
Okay.
Others have IT issues and technical barriers. So we're trying to connect those labs to the National Kidney Foundation that offers free help to labs. Mm-hmm. So it's a different route to address really the same problem, but you have to tackle it from different directions.
Yeah, I think what you said about, and say it again, that your goal here is addressing the financial barriers.
Yeah. In equity-based benefit design, our goal is to address cost barriers, why people aren't getting the care they need. It's because they can't afford it. And we know disproportionately in DC, our Black and Brown communities at higher rates report cost as being a barrier to seeing a doctor. Like over 12% of Latino community, that's more than 1 in 10 members of Latino community report cost as a reason not seeing a doctor, compared to about 5 or 6% of white residents reporting cost as a barrier.
Okay.
So equity-based benefit design removes those cost barriers, the deductible, the co-insurance, the copay, and makes certain care free for conditions that disproportionately impact communities of color. And we started with type 2 diabetes because it everywhere in the US.
Yeah.
And
especially
DC.
here.
Exactly.
Yeah, it's like a statistic that sticks out to me in terms of United Medical Center, which is located in Ward 8, but something like 80% of the patients who are admitted also have diabetes, in addition to whatever else that they actually came to the hospital for. So that is definitely a thing there. We've been joined by Councilmember Zachary Parker, who's a member of this committee from Ward 5. Ashley, if you could do the 10-minute clock, and then Councilmember Parker will let you get settled, and then we'll turn to you. So speaking in terms of some of these things you mentioned in your testimony about the HIV care that you all anticipate rolling out in 2026. What is the anticipated cost to implement a program like that?
So this is equity-based benefit design. And for us to, so we had to, we have a working group, a standing working group that the board established years ago called Standard Plans Working Group. And they're responsible for figuring out how benefits work, meaning what should be included, at what cost sharing levels, and all of that has to be done within the actuarial value set by the Affordable Care Act standards. So everything we do, all of our benefits have to fit within the actuarial value measured by what the federal government calls AVC, another acronym, actuarial value calculator. So the group has all the health plans that offer coverage through DC HealthLink, has brokers like Janice Davis testified earlier, she's on that group, has consumer advocates and experts we bring in on particular areas. And so for HIV, we worked very closely with experts from Whitman Walker, who made a set of recommendations on what benefits should be covered without any cost sharing. And the group, and we have our external actuaries that helped us figure out impact on AVC, on the actuarial value calculator. So the group recommended removing all cost sharing for primary care, family doctor, for example, for HIV.
Right, so it would be no cost to the patient, but in order for you all to do this, are the carriers just saying, okay, no problem?
The impact on AVC was very little, removing these cost sharing features. And for some benefits that we've looked at long term, we believe there's actually going to be a cost savings. In fact, there are several studies out there that were done on type 2 diabetes. If you take your insulin, your medication, and keep diabetes under check long term, you're preventing more significant costs associated with type 2 diabetes, including comorbidities like heart disease and other elements that occur if your type 2 diabetes is not under check. So there's lots of literature out there looking at short-term and relatively inexpensive investments and long-term savings on healthcare costs. We don't know yet whether our type of design and what we've done will result in that. Our goal with changing our design is to make sure that People who cannot afford these services now get the services now. So we didn't do it with the goal of savings long-term. That would be nice, but our goal is to save lives now and make healthcare more affordable now, especially for our communities who we know are telling us they can't see a doctor because of cost.
Okay. Let me ask some questions about some of the grants that you all do. So the Assister Grant Program was budgeted for, I think 1.05 million, and you all spent, I think 934,000 in FY24. That's for the Assister Grant Program, but then grants to assisters totaled around 684,000. So Mary Center, Whitman, Walker, and Community of Hope. What was the difference between these two funds?
What we budget over $1 million, that includes our DC HealthLink assisters as well as our business partners. Our business partners include the 3 largest chambers. So that total that you just referenced, over $1 million in grants that we budget every year, that includes both our assisters as well as our business partners.
Okay, so in terms of these grants, how do you evaluate for effectiveness? I.e., what are the deliverables that you're looking for specifically with the organizations, whether it be the businesses or, the FQHCs that you're partnering with?
We look for different types of deliverables. Some organizations, like the Sisters, are specifically authorized to do enrollments for us, not just outreach, although outreach is definitely in all of the grants, but actual enrollments. And specifically, our assisters are trained in how to enroll someone in DC HealthLink coverage. But if it looks like the person is potentially eligible for Medicaid, also to help them, to help the resident get into Medicaid. That is not something that we expect our business partners to do. For example, the chambers that we work with, they're not enrolling anyone. That is not their function. They help us be a trusted voice in the community, and they generate leads for us. Our team and brokers they work with and we work with follow up on leads. They help us do a lot of outreach. There's a difference. When I talk to a business owner, I'm perceived a certain way, but if it's the DC Chamber or Nicole from the Greater Washington Hispanic Chamber talking to a business owner, it's just different. So we need all of those messengers to help educate employers as well as DC residents that we're here, and we want everyone who wants affordable quality coverage to come and get enrolled.
Yeah. Is there a difference between the small business partnership grants and the small business outreach grants that you all do? Or is that technically the same thing?
So we have a couple of different types of grants. We have grants to assisters. And as you know, under the Affordable Care Act, state-based marketplaces are supposed to have navigators. We call our navigators assisters. So that's a very specific type of grant, and we expect actual enrollments in addition to outreach and education. Our business partners are the 3 largest chambers, and so they do outreach and help us with education. And then separately and apart from those two groups, we have a much smaller amount of grant funding for 2 grantees helping us with healthcare for childcare. We started with about a handful of grantees that helped us initially with enrollment, but now the program has changed to focus on health insurance literacy. So we have 2 grantees under that. Those are the only grants we have. They may be labeled in different ways, but those are the 3 buckets that we give out to groups and
Okay.
entities.
That's helpful. Let's talk a little bit about healthcare for childcare. In the pre-hearing responses, we asked in terms of like the number of facilities. You all provide the number in the aggregate. One question I wanted to ask specifically was how many new facilities joined in FY24?
I'm going to have to, I don't have that at my fingertips. We will follow up with you on that data point.
Okay.
Mm-hmm.
You mentioned in your
just in FY24, not plan year 24.
Oh, sorry, plan year 24.
Okay, we'll follow up with you for plan year 2024. How many new employers enrolled?
Right. So you mentioned this in your testimony around the wait list was implemented in January, but there are currently no facilities on the wait list.
Correct.
Okay. So it's not great that we have a wait list, but nonetheless, it's not like I have 30 facilities right now who are banging on your door trying to get in.
Correct.
Okay. There are 3 OSSI-funded FTEs that you all still have to help administer healthcare for childcare. What are those folks doing?
So we had, for FY24, I believe, we had funding for 3. It's no longer, it was from a federal source of funding that OSSI was able to use. That is no longer available.
Okay.
But just to recollect everyone's memory, when we were establishing healthcare for childcare, we essentially pulled internal experts from different divisions and made a healthcare for childcare team. A quite significant number of experts we pulled from other divisions. And at the time, OSSI was able to provide a little bit of funding to support that work. The rest were completely funded by us, our FTEs. And so now it's just 100% funded by us, that team. It's still the same team, and there's just no other funding to support the work.
Okay, I'm over time. Councilmember Parker?
Thank you. And it's good to see you, Director. I want to first praise the work that your team has done. I'm looking at this stat that 97% of DC residents are covered, which is significant and points to the great work that we're doing as a jurisdiction. And it also points to the fact that other states can learn from what this state is doing. And I use that word intentionally. I wanted to highlight one of the things you talked about prior to the fire alarm, which was eliminating co-pays for HIV care.
Mm-hmm.
And I think that is amazing. And I'm glad that you all are doing that. If you can elaborate on what led to that determination, it's my understanding it's more of a racial equity focus, given that such a significant portion, I want to say upwards of 70% of individuals with HIV in the district are Black and brown. But if you can elaborate what led to that. Part 2 of that question is, my team is currently exploring how we might eliminate co-pays for HIV prevention, namely through the expansion of PrEP, or pre-exposure prophylaxis, and what might be some of the barriers in our ability to do that. So what led to the rollout of eliminating co-pays on HIV care? I'm really glad you all are doing that and leading in doing that. And then what might be potential barriers in our efforts to expand that type of elimination for PrEP and people gaining access there?
Mm-hmm. Well, thank you. And thank you for all your help with our outreach. Very much appreciate you being out in the community and letting them know that we're here to serve the community. So as part of our equity-based benefit design, we've identified conditions that disproportionately impact communities of color in DC. And every year, we take a deep dive into one of those conditions. So we started with type 2 diabetes, then we looked at pediatric mental health, and this year, heart disease, stroke, and high blood pressure. All of those are now no cost sharing, or in the case of pediatric mental health, $5 cost sharing, and outpatient care otherwise is no cost from your family doctor, and that includes generic medication and other services. So HIV was a directive for us as a benefit to look at next. And this, in 2024, our standard plans working group took a look at who is impacted and how they're impacted in DC. And we learned that 71% of people living with HIV in DC are Black, and about 9%, 8 or 9% are Hispanic. So this condition in DC disproportionately impacts our Black and Brown communities. We also took a look at national data, how HIV patients are identified with HIV, and how patients get access to care where they're virally suppressed. And there's a difference shown through data nationwide that if you're white, and you're more likely to get your diagnosis, and you're more likely to get virally suppressed, meaning you get the care that you need, that compared to Black and Brown residents all across the nation. So we know that patients with HIV who are members of Black and Brown communities are not getting the care they need at the same rates as white residents. So for next year, as part of our equity-based benefit designed to include HIV, there's no deductible, no copay, and no coinsurance that you'll be charged when you visit your family doctor, your primary care physician. As many visits as you need, right? And different patients require a different number of visits, so there's no limit. It's no cost to you when you get your outpatient HIV care, generic prescription medication, no cost. Lab work that you need, no cost. And we believe eliminating those cost barriers will save lives.
That is absolutely tremendous. I do have a quick follow-up, and I do want to get to the PrEP expansion. Might related complications from HIV be included in that? So, or are you talking about treatment for direct, I don't know, HIV prescriptions, if that even makes sense, are covered? So let me give an example. So let's say I now have kidney failure, which is a complication of HIV. Would that fall under this prohibition?
No. So we were very intentional, and also a good example is type 2 diabetes. People with type 2 diabetes have comorbidities, meaning highly likely to have high blood pressure, heart disease, and other conditions. So we were very intentional. To comply with federal guidelines on actuarial value, you can't cover everything. Understood. Because then we would be out of compliance with basic federal standards. So it's always a trade-off. How much can we cover and stay within the guidelines? So we were very intentional in just going very direct for the condition, no comorbidities.
So do you spell out exactly what is covered, or is it on the doctor's part that say this treatment is in direct relation to HIV?
We have very detailed guidelines that we work through with medical experts and our health plans, including, codes.
Gotcha.
What unfortunately we could not do, and we hope to eventually go back to do, is to include, we only were able to remove cost sharing for generics. And we know that many HIV patients need name brands. So we were not able to include name brands in no cost sharing.
And what was the barrier there? Cost?
Cost.
Gotcha.
It drove us out of compliance with the AV.
What is the cost differential to be able to include name brand drugs?
It pushed us out of actual value compliance. It was tremendous. So what our health plan's committed to do is utilize other existing available programs that help HIV patients get the medication they need, which also includes the ADAP program and other privately sourced programs. But this is something that we'll be watching very carefully and working with the health plans to see what happens to that population where generics are just not an appropriate treatment option.
I think this is amazing. The best news I've heard all day. And I'm going to help you all spread the word because I think that's going to make a big difference in providing access to care for a lot of people. In my last minute, if we can just talk briefly in terms of eliminating copays on PrEP, which is something I'm interested in doing, and what might be potential barriers in achieving that.
So right now, and I say that intentionally, right now, it is still the law that PrEP is considered a preventive benefits under the Affordable Care Act and should be provided by all health plans at no cost to the patient. Now, we have.
So is it your assertion that there is currently no copay currently?
Correct. Now,
because that's not my understanding.
We've had complaints from customers, and we continue to work through those complaints where the complaint is that the health plan still has a copay that's being charged when the patient goes to the physician. So this is something that we've been working through with our health plans. This is an issue that first materialized a few years ago that we became aware of, and with the prior federal administration, we worked very closely, and they issued guidance to the health plans in how PrEP works. So this is an ongoing challenge. And I'll compare it to what happened first when the ACA was passed and preventive benefits were made free. It took years, and in some cases, it's still taking a case, to fix that. Preventive benefits get coded incorrectly, and then the patient is charged at the point of service. So it is an ongoing challenge with preventive benefits. It's been a challenge since the ACA was enacted. It's especially a challenge with PrEP. And we've been working on this with the health plans for the last couple of years to address.
Thank you. I am aware that there is also a lawsuit that may change a lot of these dynamics. I'm over time, but I want to thank you for your testimony.
Thank you.
Thank you, Councilmember Parker. Did you need more?
I had one other question.
Yeah, if you want to go ahead.
I just have one other question. I'm going in a different direction. Just to close out on that, my team will follow up with you about the PrEP issue as we're actively working on it.
Thank you. And if you can just send us any consumers who are having issues, it's really helpful as we work through those with our health plans. And once we make the health plans aware of the issues, it gets fixed, especially with re-education and recoding. So please send us any complaints you're getting or any cases.
Will do. I wanted to ask about the DACA eligibility for ACA, and this may have come up already, but I see that you're highlighting this as one of your major accomplishments. I was glad to see it. If you can just speak to how the program or access is playing out currently, and what are some contingencies you all might be planning for if there are disruptions given our new friends down the street.
So as you know, the prior federal administration clarified that DACA, or I call them the Dreamers, have access to lower premiums through ACA marketplaces. In fact, the former HHS Secretary Becerra did an event at Mary Center that my team and I were privileged to be at to help. So all state-based marketplaces and the federal marketplace changed their system to welcome DACA status people everywhere into ACA coverage. Unfortunately, there were lawsuits, as you mentioned, that were filed. And so in some states across the country, that access to affordable coverage through the ACA is no longer available to DACA. In DC and in about half the other states, it still is. So meaning DC HealthLink is open for residents who have DACA status to come in and get ACA lower premium coverage through us. Until there's a law that's changed, that is current law in DC. And in addition to that, we adopted a special enrollment period to help DACA residents enroll if they miss open enrollment. They can enroll even after open enrollment is done. So as long as it continues to be legally allowed, then we have an opportunity for all of our DACA residents to come in and get affordable coverage through us, and we welcome the dreamers.
And do you have the number of folk registered or dreamers that are currently registered?
We only know what's reported by the federal government, and the data, the last data I saw, there were about 400 people.
Okay,
And that's federal data.
Awesome. Thank you. That's all I have.
All right. Thank you, Councilmember Parker. Director Kaufman, I want to follow up sort of on something that you were talking with Councilmember Parker about in terms of what was happening with PrEP around. We have a plan, a benefit plan. There is a law to follow said benefit plan, and then you still have some carriers who may not be doing their part. At what point does DC HealthLink escalate something to the Department of Insurance, Securities, and Banking as it pertains to a particular carrier who is not in compliance with DC law?
So with PrEP and many other
Yes,
cases,
that's part of it, but there are many other situations where, we have what the law says here. I imagine if you get a number of complaints, maybe the first or second one you all are trying to resolve individually, but at what point do you all escalate to DISB, who is the regulator for that market?
So we've had a very good record of resolving cases directly with our health plans.
Okay.
We do share some information with our sister agency, DISB regulators, because what we see with our customers is not unique. PrEP applies beyond DC HealthLink. So if there's a systemic problem, then it's really important that DISB knows that what we're seeing, because it may be more systemic. But we have on PrEP specifically, we know it was most of the issues were at the point of service. It was the wrong code that was being used, and that's why billing code, and that's why the patient was being charged. So a lot of re-education is necessary, and that's consistent with the ACA preventive care benefits generally through the years. It's gotten better. We haven't heard in years about your annual visit, your annual checkup being charged for, as a problem. So it's not, we have not seen systemic issues with PrEP. It's been one-offs, and working with the health plans, they're able to take care of it.
Okay. Similar, but a little bit different from PrEP. As you know, and you mentioned, the district recently expanded access to fertility benefits, and obviously in Plan 2026, it will be part of our essential health benefit package. But in the right now, our office has received a lot of emails from folks trying to figure out how to sort of access this benefit. And It's kind of an interesting education for folks. So they're like, well, I work for a DC company, but they're headquartered in Texas. And so, you know, do I qualify? And having to explain to people, well, it depends on if your company is purchasing their insurance in Texas and not, you know, district-based here. We don't actually have any control over that. And for some folks, they actually happen to be, their companies are in states where they are about to do this. So California, for instance, where, you know, Governor Newsom just signed this last year. So this is going to be a new benefit that is offered there. But we have had a situation in particular where, and you and I have talked about this, right? Where I get a call from someone, they are saying the insurance company is saying we don't cover it. And I'm like, I know that's not accurate because I spoke to the company myself in March. For all of the folks, I spoke to every insurance company that does business in the district to talk about this. What is the best way for us to resolve some of these issues? I have excellent staff, but they don't necessarily know the various ins and outs of every particular case. And I'm not sure if, is your team the appropriate folks to talk to individual constituents around like, hey, can you give us this information and we can check to see if your plan qualifies, because there are some caveats, right? If it's a self-insured plan, it's a little bit different than if it's a, you know, XYZ.
Well, I think you've just identified why our system in the US is so complicated. Because, you know, if you have Medicare, there's one entity to talk to. If you have Medicaid, it's someone else. If you have private coverage, it depends what kind of coverage it is. Okay, so just going back to the fertility treatment and implementation of that new benefit, because it is market-wide, at DC HealthLink, we're in support role of DSB. So as we get questions about how the scope of the benefit, what's covered, what's not, how does it work, we get we collect those questions and we share those with DSB.
Okay.
So as they're thinking about how things work and what kind of FAQs to issue, what kind of guidance to give to the health plans, they're privy to the kinds of questions we receive. So we share those with DSB, and then DSB is in charge of interpreting what the new requirement means. It is market-wide. You never want, you know, different agencies, different entities interpreting the same requirement, because that's chaos. And anything that's market-wide is DSB. So on this fertility treatment, the new benefits, we defer to our sister agency, DSB. On your question about how to help residents and workers in DC who work for a non-DC business. Number one, it depends who they work for. At times, they may work for a state government, and that plan is usually regulated by that state, if it's a state employee plan. If it's a private company, the private company could be self-funding or self-insuring, same meaning. The only oversight over that is the US Department of Labor. It doesn't matter where the company is. Unfortunately, because of federal preemption under ERISA, a state insurance department or anyone else, as much as they want to help, they have no authority over self-funded, self-insured ERISA plans. That is the US Department of Labor. That is the best place for people with issues, with problems to go to. If their employer is not self-insured, in your example in Texas, but is buying coverage through an insurance company, then we may be able to help if the employee actually is here. And if you send the case to us and we can't help, we'll work with DSB to see if they can help. So sometimes we can help. If we can't, the US Department of Labor can always help as long as it's job-based.
Employer-based care. Okay.
Exactly.
You're right. This underscores the ridiculousness of the healthcare system and the idea of like, oh, if it's a self-insured plan, you got to go to the US Department of Labor. which is a massive entity. Love DOL. Shout out to all the federal employees who work there. But it's just kind of like, I'm a constituent. I can't even go to my state or jurisdiction for help with this particular issue because the federal government has said there's no state-based oversight over these types of plans, which is very interesting. Speaking of the federal government for a hot second, has HBX tracked the proposal that was in one of the continuing resolutions that would give congressional employees the option to purchase their health insurance through the FEHP plan as opposed to having to buy it through the exchange?
We're aware that was proposed. We have no position on that.
Okay. Lots of movement happening in the health space of things. The other thing that I just wanted to ask, I know it's fresh, but I still feel like I have to ask sort of in this performance oversight setting, and I will be asking this of all of the agencies in the health cluster, but what impact, if any, do you anticipate the recent memo from the Office of Management and Budget about blocking disbursements of grants and loans having impact on the exchange? I know there was a stay, but I think we need to sort of plan ahead. I have a list somewhere of all of the federal grants, but I can't remember off the top of my head if you all have any specific federal grants that are not attached to tax credits and other things.
Okay, so the only thing I can say with certainty is lots of chaos yesterday, lots of uncertainty. We don't know what the directive from the federal government means. Their further clarification added further confusion. And so what I can promise you is as we learn more and understand the scope of the directive, we will share with you and the mayor's team and other officials here implications for DC HealthLink and our customers. The good news, as you mentioned, is that there is a stay on that action. So for now, it's everything has to continue as the current law says. The judge put a stop to that OMB directive to federal agencies. And then just separately, it may be helpful to provide some background. So we administer a federal program under the ACA, health insurance tax credits, essentially. And the way it works is we determine what residents are eligible for in federal health insurance tax credits. And if they're eligible and the amount they're eligible for, they see in lower premiums every month. So it's a program that's the best analogy is job-based coverage. Your employer contributes, you contribute, and then you get your health insurance. In this case, the federal government contributes, you contribute, and then you get your health insurance. So on the monthly basis, if you qualify for health insurance tax credits, you just pay your share, and the federal government pays the rest. So that's the program we administer. And in looking at these new federal directives, that's the piece that we're focusing on. But what's really important is the law of the land now is you get your lower premiums. That has not gone away. And I want everyone to know, sign up. You can get premiums as low as $13 a month through DC HealthLink. Don't miss open enrollment. Get your lower premiums. Friday is the deadline. If you qualify, your premiums can be as low as $13 a month. That is currently the law of the land, and don't miss your opportunity to get affordable quality coverage through us.
Let's talk a little bit further about some of the coverage offering pieces. I see that in terms of dental, because years ago, someone had the great idea to say that your teeth is different from the rest of your body in terms of insurance coverage. But I see that, so the dental plans have remained the same. How many new folks did you have sign up for dental only coverage? And in that, do you all promote that you have a dental only option available? Obviously, you know, we want folks to sign up for the full coverage, but some folks forget about the dental piece, and then you are in trouble when you need it from an emergency standpoint. So yeah.
I will get you the data point on how many new customers we had sign up for dental.
Okay.
And then in terms of our dental market, so when we were establishing DC HealthLink, we did not know that there is no private market on the individual side for dental only coverage. It was unheard of. You could, if you were buying coverage on your own, you could not get just a dental policy or health insurance plus dental. It didn't exist. Dental coverage was pretty much a group coverage benefit. And so when we were establishing ourselves, we built out functionality for dental only coverage. And it was a great surprise that we helped create a whole market that didn't exist. So dental only, you can get through us. You don't have to sign up for health insurance through us. In fact, we have many people who only have dental coverage and not health through us. And those are the folks who work for employers who may have employer health coverage, but no dental. We also have some folks who have Medicare, but no dental, and so they can get dental through us. And of course, our health insurance customers can also add on dental.
Yeah.
So we are very thrilled with the private market we've been able to create using DC HealthLink for residents to get dental insurance.
When you all have, in terms of your data, are you able to disaggregate how many of your dental only folks are Medicare beneficiaries?
We can proxy by using age 65 and over.
Okay. I just think that's so curious. Again, with this sort of like Medicare doesn't offer dental plans. And so folks have to go find dental coverage at a time in their lives where they might have a strong need for this.
And we believe, just like you, we believe dental is part of the entire, taking care of the entire well-being. Dental issues could lead to death.
Yes.
And you know, I remember not too long ago, there was a boy in Maryland who died, totally preventable, had his parents could afford to take him to a dentist to get diagnosed, right? It was too late. By the time he had an infection, I just remember the hospital did all sorts of interventions, expensive interventions, right? And couldn't save the little boy. And this was just, you know, this was all before the Affordable Care Act, but it just, those kinds of cases remind you dental is absolutely part of your well-being.
Yeah. And what about vision?
So
you have glasses, I wear glasses, I have contacts on today. No, so it's a part. I learned a lot about vision when we went through the health occupation revision bill in the past year, right? We've got ophthalmologists, optometrists. It's different, but the vision, what's happening in your eyes is similarly important.
Yes. So there are restrictions under the federal health care law on what's state-based marketplaces and the federal marketplace can offer. And vision is one of those. We cannot offer that. But we do have an arrangement with VSP. And we have a link to VSP, and they offer our customers a great vision benefit. So you can click on that. It's right on our website, dchealthlink.com, and buy vision through VSP, but we don't establish any standards for that. It's just a way to get people to VSP, essentially to give them access. And I forgot to mention you asked on dental how we advertise our dental plans, and I forgot to answer that. So we built a consumer decision support tool just for dental, just like we have for health. After we built it to help people choose the best plan on the health side, we built one for dental. So if you just need dental coverage, go to dchealthinc.com, choose shop for dental, and you can put in what you're looking for, and that tool will just give you what the best dental plans are for you.
Okay.
Years ago, we tried to advertise for dental. I think we may have had bus ads for dental. It didn't generate a whole lot of outcomes in terms of enrollments. So, and that's very expensive, but we do have that decision support tool.
Okay. Can you just quickly describe the difference between auto enrollment and active enrollment?
So we do auto renewals, just like when you have job-based coverage. If you do nothing during your open season, your plan just renews.
Okay.
That's exactly what we do.
So active is another term for active. Are those, should we consider those new?
No. Thank you for clarifying.
Okay.
So active are people who shop and switch plans.
Okay.
And we always encourage people to shop because as premiums change, as sometimes benefits change, there may be a better value plan. And as people's health changes. So shopping is good. You can save money shopping. And I'm saying this because we're still in open enrollment. Even if we've renewed your plan and let's say you didn't have an essential plan, if you want care without any deductibles, then I encourage you to shop and especially take a look at our essential plans.
Okay. I want to ask about call center operations. So for those who don't know, we have a contract for our call center in terms of the operations there, and we do keep track in terms of how many calls they're handling and like what's the average wait time, because we don't want someone to be on the phone waiting for 30 minutes just to get a question answered. You shared in the pre-hearing responses that the call center handled a little over 71,000 calls in FY24 with an average wait time of about 2 minutes, which I think is not bad.
Better than most places you call, especially that.
I wanted to ask though, how have these metrics in comparison to the previous year, as well as industry standard? So are we seeing less calls this year, or and what might you attribute that to, or do we see more calls this year?
So I just want to comment that as a shopper myself, when I call airlines or other entities when I have an issue, when I have to wait a couple of minutes, I'm jumping up and down. Usually it's a lot longer. So I'm very pleased with all of the improvements that my team has made working with our vendor to improve the wait times and also to deploy tools that essentially, if you can't wait, then we can call you back. So every 60 seconds, you're given a choice for us to call you back. And then when we have higher than normal call volume, we also have a new approach where we tell our callers higher than normal call volume. We even post it on our website to just give more information, more transparency, so people can decide, do they want to hang up, call back, or email us. I don't know what the industry, I don't know if there is an industry standard for ACA marketplaces call centers. That's something we can take a look at. But I can tell you that every year we've had better outcomes, better quality of the calls, and we listen to calls as part of our quality assurance and improvement. And you and I both remember when we first opened in 2013, at times at the end of open enrollment, an hour and a half wait times, which was completely unacceptable. We haven't had that in years. We worked very hard to make sure that our vendor has the right staffing levels, the right expertise, and that we support them in the right way. There's ongoing training. Anytime they onboard a new class of customer service reps, there's long training, there's shadowing existing customer service reps, and there's a lot of quality assurance and quality control. So we're very pleased with our average wait times, which is, a few minutes.
Okay. On that, in terms of your contract with Maximus, we're still using them in FY25?
Correct.
Okay. For last year, you all spent about 5.5 million on call center operations. Was that exceeding what was budgeted?
I will double check. During Medicaid unwinding and preparing for Medicaid unwinding, we weren't sure if we would get what kind of calls we would get, if we would have call spikes. It was just a lot of uncertainty. So we planned for a lot of extra stuff, meaning higher call volumes, calls that we can't help. If it's a Medicaid call, most of the time we can't help. You have to call the Medicaid call center. So we budgeted a whole lot. I'll have to follow up with you how much we spent and what that looks like.
Okay. I'm asking because it looks as though you all have allocated about 3.7 million in FY25 pre-encumbrance. So that makes sense if you budgeted more for the Medicaid wind down than perhaps what a normal year might be.
Exactly. So we did, based on how much we actually spent, we did lower what we needed for our call center. But and our call center contract is a council-approved contract. So if we need more than what you approved, we would come back and ask for additional funding. But right now, we're on track, and so far there are no surprises.
Okay. Speaking of the Medicaid wind down, you all shared in your pre-hearing responses that the assisters did, I'm going to call them proactive calls to individuals who were no longer eligible for Medicaid coverage after the public health emergency was over. You all said that you did about 1,000 calls and 640 emails as of January 1, 2025. That's cumulative, correct?
Yes.
Okay. Have we seen a slowdown in this particular effort?
So the bulk of the redeterminations have been done, and we get reports from DC Medicaid Agency of people who lost Medicaid who are likely eligible for DC HealthLink coverage. And we continue to get those. And so we continue to assign those households and those residents for our DC HealthLink assisters to reach out to. In addition to the emails we send, we also use text messaging with an ability to respond. So if a person wants our help to enroll in DC HealthLink coverage, they can text back, yes, they want our help. And we will especially follow up with those people as a priority because we know they need our help.
Okay.
But we continue to assign cases as we get the information.
All right. And one last question on contracts. You all have a contract with a vendor by the name of Idea Crew, which is IT systems enhancements. In what was sent to us, it seems as though you all have two separate contracts with this vendor, and maybe it was a typo or we're not necessarily reading it right. So one was 8.5 million for system enhancements, and then there was another $7 million contract with them as well.
So there's only one contract we have.
There's only one contract. Okay.
I will look into that you're looking at.
Okay.
I'm not sure if we just made a mistake in the way we articulated. Now, Idea Crew is a CBE, and they do a number of different things for us. They are our primary IT vendor. They do operations and maintenance. They also do development work on the DC HealthLink system. In addition, if you recall, we have a partnership with the Massachusetts Health Connector for Business.
Yep.
So Idea Crew also provides that IT support for our partnership with the Massachusetts Health Connector for Business. We have one council-approved contract with option years, and that covers all of those components.
Okay. All right. I don't have any further questions. I think Councilmember Parker has any further questions. We have a list of the follow-up. Oh, yes.
So I can't remember if I said this before the fire alarm. So if I can just have an opportunity to say something about the Inflation Reduction Act, in case I didn't say it before.
Okay, sure. Yes, go ahead.
Okay, so I can't underscore enough the importance of Congress not taking away lower premiums that currently exist. Those lower premiums, health insurance tax credits in DC primarily help self-employed people and small business owners who buy coverage on their own to have affordable health insurance coverage. 1 in 4 of our enrollees qualify for those lower premiums. This is middle class families, middle class workers, lower premiums, health insurance tax credits for middle class families and workers. And it's very important to continue to help our self-employed people, entrepreneurs, small business owners who have workers, but don't provide coverage on the group side to help folks stay insured. Without those lower premiums, they will not be able to continue staying insured, and that will have ripple effects for our community. And I know this is an issue that all of the chambers raised this morning, and I just want to say how appreciative my whole team is for their help to elevate this issue, and we'll be coming to you for help to help advocate for Congress to act to keep lower premiums for small businesses, self-employed people, and middle-class working families.
Thank you, Mila. I feel like you gave a better ringing endorsement for the Inflation Reduction Act than perhaps the prior administration does. Because I don't think a lot of people knew that what they were seeing in terms of lower healthcare came from this piece of legislation and how incredibly important it is. And so when people are talking about repealing everything in the Inflation Reduction Act, it's like, okay, but small business owner, these are constituencies for whom some folks feel like that is their only constituent for whom they need to listen to. And so I think the more that we can explain impact, right? 1 in 4 of our enrollees are getting this this benefit, I think is super important in the conversations that we have in the coming months. So I want to thank you again for being here. Thank you all for your patience in our brief pause that we had to take here. We have some follow-ups. I think hopefully your team took them down. We took them down as well, and so we'll do that. But thank you so much. We're going to turn to the Food Policy Council.
Thank you.
Thank you. Okay, so I'm now going to call up Caroline Howe, who is the Food Policy Director for the DC Office of Planning. She'll provide testimony. If you give us a minute, we're going to do some musical chairs movement here. Earlier, before we started with Mila, I did give a little bit of background about the Food Policy Council, but just for folks, it's 12 public members appointed by the mayor, approved by the council, 10 ex officio members. And, they're tackling issues related to the local food economy and food access across the District of Columbia. Good afternoon. So before you begin, I need to swear you in. So if you could raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. Please begin.
Good morning, Councilmember Henderson, Councilmember Parker, members and staff of the committee. My name is Caroline Howe, and I am pleased to testify today regarding the FY24 performance of the Food Policy Council. I'm proud both of the work of the food policy team at the Office of Planning and the Food Policy Council itself to support the vision of a sustainable, equitable, and just food system for all residents of the District of Columbia. Together, we've built meaningful collaborations across agencies to ensure that all of our nutrition benefits are reaching those who need it most and that our food system is being managed holistically. We're focusing on balancing land and investment needs to integrate urban agriculture and affordable housing. At the same time, we're collaborating across agencies to integrate transit planning, land use planning, and food systems planning, ensuring that we're effectively getting people to food and food to people. We've worked to build strong relationships within the Office of Planning to integrate food systems planning into neighborhood level and citywide planning initiatives, such as the Nanny Helen Burroughs Small Area Plan and the upcoming Comprehensive Plan. Additionally, we've built intersectional research projects to understand the scale of hunger on college campuses, particularly challenging for our BIPOC and LGBTQ students, and to examine food insecurity among recent migrants and among our LGBTQ community. This intersectional approach is serving us to best understand how to serve our most marginalized communities and build meaningful and sustainable interventions. I'm particularly proud of the work the food policy team did in fiscal year 24 to support the district's participation in Summer EBT, the first new federal nutrition program in over 50 years. The Sunbucks program brought over $7 million federal dollars to give $120 each to 58,000 children in the district, in addition to a further $1.5 million federal dollars in administrative funds. This enabled families to purchase groceries while schools were out of session this summer, when students couldn't receive those school meals that so many rely on. When paired with our robust, ongoing, federally funded summer meals program, this meant more kids got more meals to meet their nutritional needs for growing bodies and minds. Thanks to our partnerships, we were able to integrate promotion for both programs, one longstanding and beloved, summer meals, and one brand new, summer EBT. We were able to bring together the Office of the State Superintendent of Education, OSSI, the Department of Human Services, DC Health, Child and Family Services Administration, and the Office of the City Administrator. Agencies each operating under separate district clusters to collaborate, share data, promote a program, process thousands of applications, and ensure that all participants were able to use their benefits and make the most of every dollar through our existing produce matching programs. The food policy team worked with the lab at DC to create an online customer service system that responded to thousands of inquiries without needing live responses. We managed customer service during the first key weeks of the program and updated the website's frequently asked questions that minimized calls to the DHS Service Center. We supported 6 community grants for outreach, enabled dozens of parent influencers to share information through trusted parent social media networks, and we trained dozens of community organizations to help families submit Sunbucks applications. We're thrilled to have been able to be a part of supporting the district to launch this essential program and learn from the lessons of fiscal year 24 to be able to support the planning for future years, which will be now run by the core service agencies for children and nutrition benefits, OSSI, DC Health, and DHS. We're also really proud to see the Food Policy Council's past recommendations now bearing fruit in policy and programs. The Elderly Simplified Application Program is making it easier for seniors and those with disabilities to apply for and renew their SNAP benefits. The implementation of the Microenterprise Home Kitchen license is building on a legacy of lessons learned from cottage food businesses and the many sessions the Food Policy Council held to listen to those cooks and food entrepreneurs seeking to serve food to their communities safely, affordably, and healthily. Prior recommendations on purchasing are now seeing meaningful implementation, including with success on reducing carbon emissions in our food system and DC Public Schools' Good Food Purchasing Program. The final 1115 waiver submitted in 2024 includes expanding the district's Food as Medicine program.
And the urban agriculture infrastructure grants and the urban agriculture tax abatement both have more interest than funding allocated to support new and existing urban farms, again, which came out of recommendations from the Food Policy Council. We continue to be thrilled that the Food Policy Council's recommendation to create Nourish DC has exceeded initial expectations. Nourish DC was able to leverage the investment of $2 million from local funds to enable loans of more than $10 million from local community development finance institutions and receive millions in federal Healthy Food Financing Initiative funds. With connections made between district agencies and local philanthropic funders, Nourish DC has been able to expand their grants to include the Keeping It Cool program, which supports cold storage for food businesses, which reduces food waste, makes businesses more able to meet food waste diversion legislation, and cuts costs for businesses during this challenging time. These programs, along with our community engagement with food businesses over the years since COVID, allowed us to make decisions this year to best structure the Resilient Food Systems Infrastructure Grant, now implemented by the Deputy Mayor of Planning and Economic Development, and the Regional Food Business Center, implemented by the National Association of State Departments of Agriculture. I'm committed to continuing to leverage all possible federal dollars to support the district's food system, acknowledging that I submitted this testimony on Friday and a lot has changed in the last 48 hours, but I remain committed to this. I'm also proud of the work we do to build community. We've brought our meetings back to in-person and hybrid after years of virtual meetings. While our breakout rooms were great chances to connect, the spaces before and after our in-person meetings and in our office hours have enabled essential connections in the public and private sector. Our roundtables with college students, migrant communities, residents in food apartheid communities, and LGBTQ service providers have offered us insight, but have also enabled connection and community-made solutions to emerge. We've collaborated with colleagues in many of the mayor's offices of community affairs, as well as the Interagency Coalition Council on Homelessness, to ensure that the food policy solutions we propose are addressing diverse cultural needs and the needs of our most marginalized residents. I remain committed to make sure anytime we bring people together, we are offering resources at the same time as we're gathering input. And I see the space we hold as being increasingly valuable in the years to come. My goal for the coming year is to remain proactively focused on the district's core needs, especially to develop the policies, programs, and partnerships to bring food to people and people to food in Ward 7 and 8. We're working with the District Department of Transportation and the Washington Metro Area Transit Authority, WMATA, to look at how transit planning can best serve those getting to and from grocery stores. We're working with DEMPED and the OP Development Review Team to see how to improve incentives and partnerships for more full service and medium format grocers, and learning from our peer cities in exploring the right role for municipal governments in supporting grocery businesses. As we enter the new comprehensive plan process, I know there are ways for us to think about land use and zoning that enables growth of needed housing and of food access without pricing out existing residents. We're working with researchers at the George Washington University to see how to meaningfully respond to the challenges of crime in grocery environments in ways that are dignified for shoppers and maintain a high-quality shopping experience. We're working with our partners in DC Health and the private sector to enable and improve online delivery for SNAP recipients while also supporting and existing expanded SNAP matches in our Healthy Corner stores. DC Health and DC Central Kitchen have done amazing work with the Healthy Corner store program, bringing produce to smaller stores. And we can learn from peer cities like Indianapolis on how to invest in more of the technical assistance we need to get more diverse, healthy, minimally processed foods to transition our corner stores to small grocers. Strategically leveraging federal, philanthropic, and local funds to support grocers in target areas will help us reach our food access goals. I also look forward to leading the Food Policy Council and the food policy team at OP to drive innovative responses to a warming world while mitigating our carbon emissions. We're looking at how heat is impacting our food workers in kitchens and in outdoor food service, how our procurement choices and reductions in food waste can reduce the district's carbon emissions. The district government has made great progress in recognizing the food climate nexus, and we will continue to work to ensure residents throughout the district will be able to thrive in the warmer, wetter, wilder weather of years to come. This will continue to be a challenging time in the district food system. Inflation has driven up all costs of living, especially food costs, which have outpaced wage growth in the region. While we know that current federal SNAP benefit levels are not enough to support families in the district, we remain committed to making sure we're taking advantage of all federal funding for food assistance by dismantling stigma and supporting more eligible residents to receive the SNAP assistance and additional programs like Sunbucks that they deserve. The Elderly Simplified Application Process, or ESAP, and other processes that make applications easier will help. I'm committed to supporting interagency collaboration that can enable the district to leverage Medicaid data to enroll students in free and reduced price school meals as well as Sunbucks. The more students are enrolled in these free and reduced price meals, the more affordable the district's investment in universal school meals will become. What we started with Sunbucks collaboration with the 211 warm line can expand to move the district towards a no wrong door approach for benefits, where clients who approach any agency for assistance can be directed to all the benefits they deserve, from housing assistance to food access. Whether that's our liaisons serving our neighbors experiencing homelessness during these cold months, or staff in community-based organizations, everyone should know both about federal and local programs to increase nutrition assistance. Thank you for the opportunity to testify today, and I'm happy to answer questions that any of you may have.
Thank you so much, Director, for that great testimony. Just want to acknowledge for folks, we've also now been joined by another member of the committee, Councilmember Felder from Ward 7. We are doing 10-minute rounds, so you'll be after Councilmember Parker. All right. Let's start with food insecurity in general. Now, there seems to be varying calculations for that rate here in the district. The U.S. Department of Agriculture reports 8.8%, but the Capital Area Food Bank reports 38%. That's a 30% difference. It was just pretty huge. Can you talk a little bit about why those calculations would be so different and which you believe is actually more accurate?
Absolutely. Thanks for that question. I do think it's shocking, and it is a lot to take in how these ranges could be so different. There's a number of reasons behind it, but first of all, when USDA is conducting their surveys around food access, families that are above 185% of the federal poverty level are not asked the extent of follow-up questions around food insecurity, based on a national assumption that if you're making more than 185% of the federal poverty level, you are not food insecure. We know in the district that many of our residents are living in between that 185% of the federal poverty level and 350 to 400% of the federal poverty level. United Way estimated that the minimum cost to live in the district was about 350% of the federal poverty level. And 36% of district households earn less than that 350% of the federal poverty level. And so we know that there's this huge percentage of what's referred to as the ALICE population, asset limited, income constrained, and employed. Those are people who in the district has been the fastest growing rate of food insecure population, because those are people who are not eligible for federal nutrition benefits because they're making more than that 185% cutoff, but are not making enough to live in the district. And so that is, we think, the biggest reason for this difference. There's a few other factors. USDA uses a 3-year average, so that includes their average of the 8% was 2021 through 2023. A lot was happening during that time. The Capital Area Food Bank uses just a 12-month period, so that's another reason why that could potentially be more accurate. The other reason why we believe the numbers are closer to that Capital Area Food Bank number is because that's also what all of our peer cities are seeing, numbers in the 30%. And we don't see significant differences in terms of the food access, or the realities of food access are not so different between the district and our peer cities. And they also have such a wide range between what USDA is measuring and what they're measuring locally. Many of our peer cities actually do that data analysis in-house.
Yeah.
But we rely on the Capital Area Food Bank for the data that they're collecting.
Okay. What you said there, Alice, asset limited, income constrained.
And employed.
And employed. That's the biggest piece, the E. Okay.
Absolutely.
I think that is like super important, but also I think this is very illuminating for folks who like, if you Google what food insecurity looks like in the district and you get the USDA number, looks very different than what the reality of what folks are facing on the ground. All measures indicate that we're seeing an increase, particularly among seniors, and particularly among Black residents. What do you all attribute to the main driver of this?
Well, certainly, as I touched on in my testimony, inflation is one part of that. We do see that the consumer price index for food was 19% higher in 2024 than in January 2020. So this massive 20% increase since COVID of the cost of food. We have seen, and that's higher than the cost of other goods. All goods have gone up since COVID, but we're seeing that price increase. Then the other big factor of why we're seeing this sudden increase is just everything that changed in terms of employment and stability pre-COVID. We did see these federal increases in SNAP during the emergency allotment, which benefited 90,000 district households during the COVID-19 pandemic. And so when those ended in February 2023, we did have a temporary pause through the Give SNAP or Raise Act, which provided that temporary increase of up to 10% of the household's federal SNAP maximum between January and September, but then those also ended. And we had a gap between when the federal program ended and when Give SNAP or Raise was implemented. Right. So we've had these multiple gaps, and we know that with additionally, given the increases in cost and that SNAP is not keeping up with that, we have this gap between even our families on SNAP are not getting enough and earning enough to
support. So let's talk a little bit about that. You mentioned in your testimony that DHS has now implemented the elderly simplified application for SNAP. Are we seeing more people sign up, or is the more simplified application actually more simplified?
It is genuinely simplified. It is a shorter application process, and there are fewer renewals. In terms of the numbers we've seen since ESAP has been implemented, I'll have to follow up with you about that and connect with my colleagues at DHS, but I will certainly do that and get back to you.
Okay. I mean, Give SNAP or Raise, I did that bill. And the cost overall has always been a challenge for permanent implementation. Absolutely. Particularly now where we are sort of in the economy and those kinds of things. But we're trying to figure out how to possibly, modify or do this even for a small percentage of the population. I don't want to put you on the spot, but if we were to do the benefit increase specifically for seniors, I haven't even talked to DHS about this in terms of if that's possible, but I imagine that is a segmented population that they could pull out of their data.
And I do think that the data piece is a real challenge, and I want to acknowledge that for DHS. It's very hard to target a specific population, which is, of course, why Give SNAP or Raise was so broad.
Right.
I do think that given the fact that we already do serve a senior supplement, that data is already pulled out, and I would, of course, defer to my DHS colleagues. But given that we do that, if we were able to pull out a set of population, senior food insecurity, you touched on the fact that Capital Area Food Bank said 38% is the new rate for the district in 2024. Senior food insecurity went from 31% to 42% in the Capital Area Food Bank's numbers. So that was the fastest growing part of that population, was seniors. And then additionally, what is not eligible for something like Give SNAP or Raise, again, that ALICE population that we're looking at what are the other policy interventions for. But in terms of populations we can serve, seniors are the easiest to pull out that would have the biggest impact in our food security.
Okay. Another area or population that has had food insecurity that we've heard of is higher education. I know a lot of people don't think about that because they're like, oh no, they're in college, they have a meal plan. Not everybody has a meal plan. And not everyone is living in a residential environment in college, particularly in our area, right? We have a lot of people who are doing different things. In your written responses to the committee, you mentioned that you all were developing a specific report on food insecurity in higher education and that you hope to publish that in April.
Yes.
Is it going to be on time?
I'm pretty confident about that. With all of our research studies, we work with quite a lot of research partners, universities, think tanks to be able to focus on specific themes that we're not able to through capacity constraints to do just within our office or even within the Food Policy Council. So that was one of those cases, and it was fascinating and remains, again, there's restrictions on SNAP for college students that I had no idea about before we launched this project.
Yeah.
That it is much harder for a college student because of those assumptions you raised, for college students to be able to opt into these programs. All of the campuses, all of the colleges that are in the district do have things like food banks and food pantries on campus, but there's all different kinds of constraints that are making those challenging, and none of those are funded by the district. All of those are funded in different ways by students or by the campuses themselves. So your question was whether or not I will get that to you by April. I am confident that we'll be able to release that.
Okay. Let me quickly ask about Sunbucks in that, right?
Yep.
It's a food insecurity piece. As you know, we had some back and forth on whether or not we were going to do this program, whether or not we were or were not. What percentage of eligible children actually enrolled?
Wonderful question. So and thanks to the Office of the City Administrator, the team at the lab was incredibly helpful in this. So I mentioned 58,000 students received funds and used their funds this year. We had, of that 58, about 40,000 of those were directly streamlined through SNAP. Another 10,000 were needed to submit an additional form to the Office of the State Superintendent to opt in, and that's where we saw the biggest drop. This year, they will not need to do that because we've received additional guidance from the USDA and the Department of Education at a federal level that allows us to more easily share that data. We did have 14,699 applications for 27,262 students. So of those who applied, 46,000 were pre-approved. They didn't need to apply, but they submitted an application anyway. And then 39,000 of those were approved. So we believe that there are 80,000 students in the district who are eligible. That's USDA's numbers and our analysis based on income and SNAP. The benefit, if we are able to use Medicaid data to pre-approve those, which USDA has allowed us to do, we would be able to automatically approve without applications between 90 and 98% of all eligible students. And that is a really big difference between having to have thousands of students apply.
Okay, I just want to ask one clarifying question.
Yes.
You said 58,000 students who enrolled and used it.
Yes.
So there must be some percentage of young people whose their family enrolled and then no one spent it?
Exactly. We had a lot of challenges in the first year with address data and with folks are moving in the district. And so I think there were thousands of cards that were sent that were never activated, which we believe means they went to wrong addresses. We in the Department of Human Services did a lot to work to make sure that people were updating their addresses. But the other big change that we're making for 2025 is that it will be directly loaded onto existing SNAP cards. So there were lots of reasons for the choice we made in 2024, but given the challenges we saw with activation, that's the direction we're moving.
Okay, thank you. Councilmember Parker.
It is good to see you again, Caroline.
Great to see you too.
I was mentioning over here, I have a cup of coffee, but you're always such high. And I love it. I love it. Absolutely love it. Before I jump into my questions, I will just say lack of access to nutritious and plentiful food shouldn't be a reality for any district residents. And we know we can reverse the situation through more access to grocery stores, farmers markets, fresh and nutritious foods, and access to benefits which help people reduce those financial burdens that you were alluding to. I'm excited to hear more about Sunbucks. As a former educator, this is near and dear to me. And as you know, as vice chair of the Council of Governments Farm Committee, we've talked about Sunbucks and how we might expand that in an effort to also expand SNAP benefits and existing programs. Last thing I would just say is Ward 5 is home to several senior buildings where the need for food access is arguably greater. And so I'm glad you referenced senior hunger as a low-hanging opportunity for us to take action on. And I want to just plug the No Senior Hungry Omnibus Amendment Act, and I'm going to keep plugging that because I think the council needs to take action on that. So with that, I'm going to ask a few questions. I'll start with Sunbucks. Chairperson Henderson asked the first question I was going to ask, but I'm going to repeat what I heard from you. 58,000 youth received funds this last year. And for those that are watching, Sunbucks is an expanded program from the Department of Agriculture where they're providing, I believe, $120 per child, and that money can be used at local grocery stores. It's
Or at farmers markets, anywhere where SNAP is accepted. That's correct.
anywhere where SNAP is accepted. And so we have 58,000 who received those funds. You said 40,000 were streamlined because of their participation in SNAP, meaning they didn't have to apply, they automatically were enrolled. I guess my quick follow-up question there is, what education was provided for families for what Sunbucks is and how it works, or did they just receive a debit card in the mail?
Great question. So before families received the cards, they received a letter outlining what Sunbucks was. Again, for those where the addresses were incorrect, they might not have received that. So super grateful for the Office of the State Superintendent of Education, OSSI, sent information out to all schools, and all schools did send information out to their students. So we know, let me just get this number. But we know that of the people who applied, who told us how they learned about Sunbucks, was through the school. We assume the same is the case for those who also did receive Sunbucks, who were automatically enrolled. They also got information from the school as well as mailed to them. And so again, of those 40,000 were pre-approved through SNAP, but then another about 8,000 were approved through their school based on what they've already submitted to their schools, but they did have to submit an additional form to
You said
opt in.
8,000 or 18,000?
8,000.
8,000.
Yep.
And that's the part you're trying to streamline this next year.
Well, certainly that part will be streamlined, whether or not we're able to use Medicaid data. We'll be able to streamline students through SNAP and through applications submitted for their free and reduced price meals, which is how people apply for free breakfast, lunch, and after school snack. Families that are not in our community eligibility provision schools where everyone gets free meals, those who have to apply, we do have those applications. OSSI also keeps data of those in foster care and those experiencing homelessness, which are the other 3 ways people can streamline for Sunbucks.
Got it. And this is a one-time deposit.
Yes, the $120 is once a summer.
One thing that I know is a reoccurring issue is theft of SNAP benefits. Were there any related issues with these Sunbucks that, oh, my debit card didn't arrive or someone else is using it?
Remarkably, we certainly had a lot, as I mentioned, that were incorrect addresses. I'm happy to get back from DHS the numbers in terms of any actual reports of fraud or someone else using it. We did have a couple of questions around custody in terms of where the card should go over the summer based on where that is the reason we issued separate cards in the child's name, was so that each child their card could go with them if they were staying with a grandparent in the summer.
And the elephant in the room is around whether or not this program will continue, given our new friends in office.
That is the elephant in the room.
Okay. But your understanding as of today, it will continue, and you're planning to continue moving forward with that understanding?
Yes, USDA treats Sunbucks as another longstanding permanent federal program like SNAP. The messages we did receive yesterday is that SNAP will not be affected. But again, there has been already legislation introduced that would have impact on the population we're talking about, students, in that it has been proposed to actually increase the percentage of students that need to be that would need to be attending a school in order for it to classify as CEP, that community eligibility provision, which allows the district to provide those free meals to all students in the school. And if that threshold were to increase, we would see many of our schools impacted and potentially ripple effects onto programs like Sunbucks.
Understood. And it's my understanding as of today, the administration has rescinded its proposed freeze on federal spending. So as you mentioned earlier, a lot can change in 48 hours in our reality. I want to move on. How does the simplified application process for SNAP differ from what's been done in the past for seniors and those with disabilities?
So the biggest benefit with ESAP is it is a shorter application, but also that they don't need to renew as frequently. So especially as DHS moves towards more in-person renewal, we're looking at that can be a real barrier, particularly for seniors. So I would defer to my DHS colleagues in terms of exactly, again, the numbers. I'm happy to follow up with them and get some more numbers in terms of how that has rolled out and what the feedback has been.
Okay. And we know SNAP is insufficient. It's an essential tool that I'm grateful for, but as you alluded, we know that the benefit is not meeting many residents' need. In fact, when we as a council passed Give SNAP a Raise, we found that more than 50% of residents in the district receiving SNAP benefits exhausted their benefits before the half of the month. In other words, they were winging it for the second half of the month. With that, what more can we do for senior hunger in the district from your perspective? Beyond just SNAP, because we know that's an important tool, but an insufficient tool.
Absolutely. You know, I think that there's so many ways that we can be working with our seniors and senior groups. Certainly, the Department of Aging and Community Living has done a lot to be able to bring meals to seniors and figuring out ways that seniors can feel safer and be returned to the idea of a community meal. We shifted to a lot of prepackaged meals, and it's quite a different experience. So I think there's opportunities for us to really think about the meals we're serving and how we're serving them when we're getting to seniors. I think one of the other things that I would love the opportunity to talk about, but I reference the idea of it's not just about bringing more stores to people, but also in the case of seniors, having ways for those people to get to food. So thinking about how are we supporting transportation for folks to be able to get from those senior housing facilities to affordable grocery stores in their neighborhoods? How are we enabling people to safely transport that food back to their homes? And of course, in the case of seniors, we're also looking at food preparation. One of the other things that we've been looking at and that DHS has been considering and is still very much under review is currently the district does not opt into the hot meals provision under SNAP, which allows seniors, people with disabilities, and people experiencing homelessness to use their SNAP benefits to actually be purchasing prepared foods. Currently, SNAP includes no prepared foods. And so the hot meals provision would allow those populations to be able to access prepared foods, which we know would certainly benefit folks experiencing homelessness.
Does that mean they could just go to the local restaurant and say, I'm using my SNAP benefits?
The restaurant has to opt in as well. And that's been the challenge that we've seen in our peer states like Maryland and Virginia. How do you really get locally owned businesses providing healthy foods?
And what is the necessary, I'm jumping in because my clock is ticking, but what is the necessary change? Is that a policy fix from us?
It is something that could happen just within DHS. I think that there's lots of barriers. It would take more capacity in order to implement the hot meals program. So I think the other ways of how we incentivize our businesses, we're really interested in that. We've seen examples like Breadcoin, which enable restaurants to really create an open door for folks experiencing homelessness to come in and get food. So how do we make it so it's safe for those seniors, people experiencing homelessness, and those with disabilities to find healthy food, to be able to use SNAP in that way?
Which at its core, I'm hearing you say, means we would have to get more businesses to accept SNAP benefits.
Exactly.
Got it. I am out of time. I see Chairperson Henderson stepped away, so I'm going to turn it over to Councilmember Folder.
Thank you so much.
Good evening, everyone. Thank you, Director Powell, for your testimony and all the work that you do at the DC Food Policy Council. I'm just going to jump right into my questions.
Wonderful.
What specific strategies are being implemented by the DC Food Policy Council to address food access disparities in Ward 7? And how is the council ensuring that underserved communities, such as those in Ward 7, are being prioritized for healthy food initiatives?
I'm so glad you brought that up. Certainly, it is a core part of our priority. We haven't to be honest, moved the needle over the last few years. Councilmember Anderson said earlier today, we haven't seen the number of grocery stores we need to. That means our interventions aren't working yet. We do have exciting projects in the pipeline. We heard from Jaron earlier today about the Marion Berry Market that Dreaming Out Loud is working on in Anacostia. Market 7 in Ward 7 has received a lot of investment from the Food Access Fund and through other funding from DEMPED. But those are very small, and it's clear that we need to be doing different things in addition to returning our investment in things like the Food Access Fund that was funded exclusively through American Rescue Plan dollars. Those aren't coming back. And as we look at how do we continue to support the businesses with the funding they need to open new stores. I think the other pieces that we're really excited about and looking into is what are the other ways we expand our work with developers in Ward 7 and the Office of Planning Development Review and other district-led developments to ensure that grocery stores are going into any of those new areas. So that can be anything like actually requiring that in any new development or streamlining the approvals for grocery development during OP's development review process that would allow a grocer to commit sooner. I think also looking at something like district-led spaces like Capital Gateway. We don't yet have a grocer in that space. How do we look at investing district dollars in creating physical infrastructure space to enable grocery stores, community-run, or local small businesses to actually be leasing district space to operate that? We also, I think in Ward 7 in particular, there are real challenges around the transportation connection to the grocery stores that we do have. So of course, the food and transit study that Councilmember Henderson had introduced last year is of great interest to us. We're also, as I mentioned, working with WMATA and DDOT because from our analysis, 65% of neighborhoods in Wards 5, 7, and 8 have both the combination of low food access and low transit access. So they're more than 0.5 miles from a grocery store, but they're also more than half a mile from a WMATA bus or a metro station. And that to me really stood out to see we need to be thinking about how we're getting transit there. The other piece to think about for Ward 7 is around online delivery. So online delivery represents a growing percentage of SNAP purchases in the district, and there's exciting pilots going on both in the district, Baltimore and Montgomery County,
Right.
are covering those delivery fees.
I appreciate, no, I love your points. We got a number of questions to
Okay.
get through.
With the other.
No, I appreciate that. How is the Food Policy Council's recommendation and information being shared with DMPED and other DC government agencies to help guide the implementation of your recommendations?
That's a great question. Councilmember Henderson referenced our ex officio members. I've expanded the number of ex officios that we have on the council to be able to represent more of the agencies doing implementation. We have a close working relationship with DMPED in particular, but I also think that there's certainly opportunities for us to expand. We have one representative for something like DC Health, where there's 5 different divisions that touch on the food system in one way or another, whether that's licensing food businesses or whether that's providing food access through things like Produce Plus. So we have more ways. I also think, we do create a lot of fabulous materials, many of which are directed towards council, but many of which are really directed towards residents. And I think we can do more.
Copy. And given the council's emphasis on equitable access to food, I was wondering why there's only one member from the Ward 7 and 8 on the council, which affects how you guys, which affects how you all are ensuring that the council has more, how are you guys ensuring that the council has more members who live in Ward 7?
I really appreciate that. And I think that that is a real challenge at the moment. I will say that we don't look at the wards of where our ex officio staff are from, but I can say that Ward 7 is represented on the council in that way. That's not something we report to you, but it is something. We will have 3 positions opening up in March. And I am really in our interviews making sure that we will have someone from Ward 7 on the council.
I appreciate that. You highlighted that one of your goals is to reduce food barriers or reduce barriers rather to new food businesses successfully launching and growing, especially in Ward 7 and 8. How is this different and or relate to DMPED's food access grant?
Wonderful question. Well, first of all, the Food Access Fund is no longer has funds remaining. It was All American Rescue Plan Acts, and that's certainly something we would love to see it continue and expand. It would have to come from, at this point, local funding or looking at some federal grants that we could consider. Nourish DC, again, is another funding source for those businesses in Ward 7 and 8. But some of the other priorities there are that some of the challenges aren't just funding. For many businesses, the confusion around how to get a license, and that remains around vending. When we look at vendors who are seeking to vend in Ward 7, how do we make sure they're also getting access to support in vending licenses, in accessing space, and in thinking about all of the other technical assistance that we do have many sources of in the district, but we need to make sure those businesses reach.
Copy. And you mentioned earlier, you were rattling off, which I appreciate all of the work that you're doing. What data do you have to demonstrate the impact of the work you're doing? For example, how many new businesses successfully launched in Ward 7 and 8?
That's a wonderful question. I think I'm thrilled to have DSLBD as one of our other ex officio members, and the technical assistance that DSLBD provides regularly, as well as DLCP. This has been the first year that we've had active participation from DLCP on the Food Policy Council, and I see that impacting what is happening and the resources that DLCP are putting forward. I do think that it is a real challenge as a food policy council where we make recommendations or we pilot programs that then other agencies implement. And I would be thrilled to share with you some of the impact of those pilots that we've launched.
I love it. Have you generated a report on the barriers that new food businesses face when trying to launch a business? If so, how is that information being shared with other DC government agencies and partners to develop innovative programs or initiatives to remove those barriers and create an increase in number of food businesses?
Thanks for that question. We did do a series of roundtables with small food businesses to understand their barriers post-COVID in particular. And I think that while we used it to both inform our policies and the work of the agencies that are part of our ex officio group, there's more that we can do to make that public to really lift up those challenges. And I think we've really approached it as a solutions first, so working with the agencies that are related to that to see how DLCP and DC Health, for example, can collectively make information really clear about how food businesses need to register.
Thank you. My next question, how does the DC Food Policy Council support local farmers, food businesses, and entrepreneurs, particularly in economically challenged areas like Ward 7? Are there initiatives that help these small businesses expand their reach and impact underserved communities?
Absolutely. So in addition to, of course, lifting up the district's programs, the Food Access Fund, Nourish DC, we run a newsletter, and in our newsletter promote opportunities that are coming from local philanthropic sources, that are coming from federal philanthropic sources, and of course, federal grants as well, to make sure that businesses know about those resources. I think we've also, in our office hours, I came from DSLBD and was a small business coach in my prior role in district government. So in our office hours, I often do have small food businesses who join to ask about really how that landscape works.
Copy. What efforts are being made by the DC Food Policy Council to create sustainable jobs within the local food system? Are there programs that support workforce development in agriculture, food distribution, or food related industries?
Yeah. So one of the things that I'm really excited about is that we've been convening two related communities of practice. So one, district government agencies that are doing procurement and processing, as well as workforce development providers in the district. The district, in our Make Food Work study, which came out in 2019, but still has some really wonderful resources in terms of who and how we are training food staff in the district. And what our hope is in these two and bringing them together is how we can have more people who are emerging from these workforce development organizations directly placed in our agencies who are seeking staff to be able to prepare food.
Probably, I have three more questions, and in the interest of time,
Fabulous.
I would
I'll
love
cruise
to be a
through
little
them.
bit more succinct. How does the DC Food Policy Council collaborate with community-based organizations in Ward 7 to improve food access and promote food justice. Can you provide examples of successful partnerships that you have made that have impacted our communities?
Absolutely. Well, I think one place is certainly when we were doing outreach for Sunbucks, we worked with a number of community-based organizations all across the city. But in particular, we've done a lot of work with the Letterer Gardens and work to make sure that we're really supporting the community as we do outreach there. We also provided grants to two other organizations, the Fauntleroy Center, which is also in Ward 7, and then organizations that serve the whole city like YMCA, but that really focused on their Ward 7 and 8 outreach centers. So both when we do have the funding to provide those kinds of grants, we do focus on getting them to organizations in Ward 7 and 8 and that are serving our target communities that are harder to reach, including organizations that are serving a Spanish-speaking community. I know there's more to do, but we also have moved our Food Policy Council meetings throughout the city, including twice in Ward 7 in 2024, so that we could actually be hearing from communities in different ways.
Okay, how does the DC food policy support urban agriculture, community gardens, and other local food production initiatives in Ward 7? As you may be aware, there's an urban garden ran by UDC that's located in Ward 7. Could you describe your collaboration with UDC or any work that you've done to support the farm?
Yeah, so certainly the East Capitol Farm is also near and dear to my heart, a place where I worked in a prior role in district government. I think that we've worked a lot both with UDC, but also the Department of Parks and Recreation and the Department of Energy and Environment in their Office of Urban Ag to make sure that we're reaching people who want to grow in any of these different ways. People who want to be growing in a community garden or more like DPR's communal gardens, and looking both at how we're supporting the existing urban agriculture facilities as well as lifting up what our sister agencies are doing. So Rooting DC, all of DPR's work in their communal gardens, and a priority this year of really building the relationship with DC Water to get more water to those farms.
Copy. My final question, and thank you again, Chairperson, for allowing me some additional time. As the district works to improve food security and build a more sustainable and equitable food system, what is the long-term vision for the Food Policy Council in DC, and how can Ward 7 residents be better engaged in shaping that vision?
Yeah, I mean, I'm really excited about as we head into the next year of the comprehensive plan to make sure that residents from Ward 7 understand and are able to participate in shaping what development in the district looks like. So that's one opportunity. In terms of how we move forward, I want to see us move into more specific community advisor roles where we have more residents who are talking about a specific topic area that we can be really thinking about. In Ward 7 and 8, of course, the challenge of accessing a food grocery stores, we've really engaged what is the question, asking the question, what do people most want? Do you want a corner store on every block that has some food? Do you want to see a massive big box grocery store? The investment is quite different, and really hearing from residents what that preference is. And that's one of the things we did in the Nanny Helen Burroughs Small Area Plan, was really get down to that level. What did people want to see in this corridor? And investment in Letterer was certainly one of them, that people could move towards food sovereignty of growing and producing and processing their own food.
Thank you.
Thank you so much. You asked me a lot of questions. I really appreciated your rapid fire. There's more I would love to say, and I will follow up with you after this.
I'm in room 406.
Thank you, Councilmember Felder. Councilmember Freeman.
Thank you very much, and thank you for all the great work that you do. One of the things that's been on the table for some time is a move to expanding our central food processing facility capacity. And I wonder if you can speak to where we are on that, what the current thinking is, and how you perceive the next steps.
Well, I'm very excited about where we are with the idea of a network of central food processing facilities. So while our report is moving through IQ at the moment, We are still moving things forward, working with many of our agencies to look both at potential sites and at potential interim steps before we are actually able to build out what will be a multi-year process of building out a central processing facility. So for those tuning in, the idea of us moving to more central processing for us to be able to produce food served by multiple agencies, but particularly in our schools, at our jail, in the Department of Youth and Rehabilitation Services, and in other sites like that to lower the cost of food procurement and increase quality. We're looking at there are some district-owned sites that could potentially be prime opportunities for us to be developing a space. I think that we're also looking at sites across the city, and with an emphasis, given the goals of redevelopment downtown, to also think about how a downtown location would fit into it. What we know, and I'm happy to follow up with more, but what we know is that we would need a total of about 170,000 square feet total for these facilities, and potentially that number would increase if we're looking at multiple facilities, but there's lots of reasons to move towards that. The last thing I'll say about what we're doing right now is in this year, thanks to the Office of the City Administrator, we've actually built collaborations to look at how we can start some aggregated purchasing for shelf-stable items to leverage the Office of Contracting and Procurement existing warehouse space so that we could actually use that existing warehouse space to store that shelf-stable material.
So very, very helpful. When do you think we will see a list of sites that you're contemplating for potential use? Where does that happen in this process?
That's a great question. I think that we're not at the level of having a list at this point. I think that was certainly our goal with our last study, and something that I'm hoping, if we are able to access the federal funds shortly through the Resilient Food System Infrastructure Grant. That's a federal grant that DEMPED is managing, but will be funding a full-time person in my office focused on procurement specifically, building the infrastructure needed for a resilient food system. And I'm really optimistic that having that capacity, which we hope will be someone starting this spring, or given some delays this week, potentially this summer. But I'm still optimistic that we will receive that funding and we'll be able to have a full-time person really digging into more of the sites and the economic analysis of being able to present to council and the mayor what it might cost up front and what we could imagine saving long-term.
So at this point, is there anything in the budget that's a marker for a future year, or are we still too early for that?
We're still, I would say, too early for that, but I would also defer to my budget colleagues.
Okay. So a second thing, and maybe to what extent do you play a role in decisions about self-provision of food service by DCPS? We just did the 5-year contract, and so one could say it's too early to think about it, but actually I think it's probably the right time to be thinking about this, the pluses and minuses of going in that direction. How do you fit into that conversation, and where do you think that conversation is at right now?
Well, I definitely think this is the right time to be starting this conversation, because I do think when we look 5 years out, that is the timeline of if we were to make an investment in 2026 for a central food processing facility, that would be the timeline by which it could conceivably be coming online if we were to start groundbreaking in the coming year. So with that in mind, I think that certainly what we're doing is building both within DCPS and within the existing vendors. How are we moving in that direction? And I think certainly this aggregated purchasing and leveraging some of those federal food dollars to be purchasing collectively. So OSSI manages bulk commodities purchases from USDA. And that serves not just DCPS, but charter schools. And currently they each have to purchase on their own. It's harder to access that commodities funding and the cost, much lower cost, because you have to purchase an entire truck of one item. And so if we are able to aggregate that purchasing, it really is the first step towards central food processing, the goal of us purchasing all of that in the district. The other thing, which as I was looking at what federal funding could potentially be impacted, DC Central Kitchen received a really fabulous federal grant last year to be able to move more of the schools they serve to having more farm-based produce going into those schools and more preparation on site. So I'm really excited to see that. I remain optimistic that they will receive that funding still, but looking at seeing how that rolls out, I think also moves us in that direction.
So, I mean, one takeaway from that is, I think you used the expression, that's clearly the direction we're going. Is it settled that that's the direction that we're going?
Wonderful question. As you may notice, I am an optimist. I do think that is the direction we're going, and I'm thrilled to see that the lab at the Office of the City Administrator did a really deep dive on what we needed to be able to be moving in both a more, in particular, their focus was the economics of the district's food purchasing. And I think that a key outcome from that is that this is the direction we're going to need to move. So I'm excited about that. And I'm excited to see that there is momentum within DEMPED as well to consider how we could integrate this into one of the district's development sites. I touched on the possibility of thinking about both how we're moving grocery, but also how we're moving central food processing forward at a place like Capitol Gateway. And I think that DCPS remains very eager and excited to see where this conversation goes.
All right, well, I really appreciate it. Excited about all of that. If you could email me a link, if it's a public document, whatever it was that the lab had done, I very much appreciate that. And
to my knowledge, it is not public, but I'm happy to put you in touch with the team there so that they can share some of their results with you.
all right, wonderful. I'm glad to hear it's not public because I didn't know about it. With that, I'm going to leave 3 minutes on the table and head up, but thank you very much for everything you do. And thank you, Chair.
Thank you, Councilmember Freeman.
Thank you. I don't know, Director Howe, you're popular. You have 4 members of the committee who've come to ask you questions thus far. So
I am pleased by the attendance.
But I do think that speaks to, a focus and interest around not only food insecurity, food access, but also food resilience and some of the conversations that you were having there with Councilmember Freeman. I want to pick up on a little bit of where I left off. So there was a 2023 food system assessment report that talked about the need for further investments in local nutrition programs like Produce Plus and home delivered meals. As you know, the council increased the budget for these programs in both of the cycles that I've been chair. For which of these programs do you think that there's still some unmet demand?
Well, I will say I don't have the number in front of me, but certainly every year, including after the budget increase, including in 2024, we had more interest in applications for Produce Plus than we had funds to distribute. And I think that that is extra relevant because given our investments in Sunbucks, our team was really focused on how do people make the most of these dollars, including anyone who was purchasing with Sunbucks was eligible for Produce Plus. And further SNAP matching, which happens at the farmers market level. That kind of market matching is federally funded. So both Fresh Farm, Arcadia, DC Central Kitchen in their Healthy Corners, all of that is federal funding through these nutrition incentive programs, which allow SNAP matching for produce. And so I think that the combination of Produce Plus constantly having more interest than space and funding at the same time as we're potentially have the risk of losing some of our other nutrition incentives on a federal level, which I will be following closely. I think that is one reason that I'm particularly interested in that. I think on the flip side, we have a really optimistic place to be coming from around the 1115 waiver that DC Healthcare Finance submitted, where home delivered meals could potentially begin to be covered by Medicaid. And that's a place where our investments really could be leveraged, and what we've piloted in the district with our home delivered meals and other food as medicine programs could begin to be funded more by the federal government. Although again, remains to be seen.
I know. And, you've been sitting here and things were clarified, rescinded, not made clear. It's still as clear as mud. what is happening with the federal funding. So you haven't missed anything. So it's all still to be seen. On that, but I also want to underscore just everything you said in that few minutes around how Produce Plus and all of these various programs are tied to federal funding, right? And so as we continue to talk about the impact piece, so I want to ask about universal free school meals. So we're about to reintroduce that legislation. And, you know, in your testimony, you mentioned how increasing federal funding could make programs in general more affordable. Again, to be seen, your prior written testimony. You know, we have struggled mightily to get the fiscal impact statement reduced for this bill. Conversations we've had with OSSI and conversations we've had with the CFO. You know, despite the new USDA rule, or I guess I don't know if I can call it new anymore, but the update on the USDA rule around community eligibility provision and what that would mean for DC. From your collaboration with other cities and jurisdictions who've already implemented this, they've already gotten to the finish line. What are you hearing about their use of CEP to lower the local costs?
One of the things that I've heard, and I will start by saying that, of course, I will defer to OSSI on the fiscal impact statement, and there are some real federal changes that could potentially be impacting that. But in terms of what I've heard from other cities, and this ties both to Sunbucks and to school meals because USDA is implementing them so closely related, is that I have seen, especially at a state level, governors requiring both agencies to use Medicaid data. And what that does is really does enroll more students directly in being covered and qualified that allow all of our percentage of reimbursement to be higher. Again, if federal government changes mean our CEP, whatever changes that happen, whether positive or, well, in whichever direction those changes were to move, it could really impact our number of CEP schools and the percentage we're getting reimbursed. But I have seen this piece around Medicaid data be a really powerful move that other states, especially at the governor level, have asked, and they haven't always needed to legislate. They've just been able to ask that it happens.
Yeah.
But sometimes that has been a move that has enabled schools and jurisdictions to move towards more economically effective universal meals.
Yeah, I think the harm in terms of relying on Medicaid data at this particular juncture is that proposed changes to the Medicaid program
Absolutely.
could significantly reduce the Medicaid enrollment numbers in a variety of different ways. And so, okay, we'll keep talking about that. You talked with some of my colleagues about grocery stores and food access. The 2024 Food Access and Economy Report was due at the end of the calendar year. When do you anticipate that it will be published?
That's a wonderful question. We are working that through the internal review process. And as of now, I also think that we will have it to you by April at the latest.
Okay. Are there any main findings that you can give a preview to?
Certainly, you touched on by asking about the data question is a huge part of the Food Access and Economy Report is to understand those. I think many of the other pieces I lifted up in my testimony because our report does lift up the highlights of 2023 and 2024. I think the other pieces that I would lift up is that the Department of Aging and Community Living and the lab did conduct a resident-centered design project around thinking about purchasing, transporting, and preparing meals towards the goals of No Senior Hungry, although again, it wasn't a funded study, it was conducted by the lab. And I think some of the other things that came out of that were expanding home delivery services, adding spots in the programs that deliver produce boxes that currently have wait lists, and increasing the amount of foods or funds program participants receive. And so we're really excited to continue to think about how we're serving our seniors. Again, we touched on that earlier. And then the last sort of significant piece that I would lift up have been other things that we've already talked about today around grocery stores and potential interventions to support more small format grocers. and to think about some of the potential investments we can make in farmers markets to particularly expand farmers markets in Ward 7 and 8, but also to support farmers markets all around the city who are such an effective producer to consumer channel for locally grown and locally produced food. And I am optimistic to see where we can move with those farmers market recommendations.
Great. In the FY25 budget, I funded a grocery delivery pilot. So we're sort of talking about this for 1,000 low-income residents who participate in the SNAP education program. This is in partnership with DC Health and Instacart. Have you been involved in those conversations around implementation, which hopefully will roll out soon?
Well, you've said more than I could, so I'm very grateful for what you've just said about the pilot. But I am very excited about the pilot, and I think we've been involved. We work really closely with our DC Health colleagues. And I think the two other pieces related to online delivery that we're so excited to see that pilot happen, which is particularly removing delivery fees. Some of the other ways, as we think about how we support small grocers in Ward 7 and 8 and expanding grocery access. Some other cities have actually looked at local matching for those SNAP and WIC dollars being spent at grocery stores. And that can be a great way to be funding grocery stores while also really providing more food. The last thing related to online delivery is it is really exciting that our Attorney General is holding companies accountable to deliver to every zip code.
Right.
And I think that that's something that's going to be important for us to continue to keep ensuring that as we move online delivery, we're making that work for everybody.
Yeah, I mean, I think that you made an excellent point when we were sort of talking about sometimes there's a benefit for the individual, but is there a benefit for the business as well? But what a lot of people may not realize is, like, when I joined the council, was really interested in wanting to talk about grocery store development. It's been a lot of time having conversations with developers who work on grocery store pieces. And, one of the things they talked about is, like, a tax incentive is not always enticing. A tax incentive is something for a moment in time in some cases, or it is to top off. But one of the things that is often a driver in a chain's decision of whether or not they're going to locate in a particular area is around, can there be a steady flow of revenue to support this grocery store? And so one of the reasons that we push Give SNAP a Raise was not just to increase the overall benefit, but it was to increase the purchasing power of folks in neighborhoods to enable their ability to support, the grocery store piece. And so to your point around, what if we did something around matching SNAP dollars in the same way that we do matching dollars for Produce Plus? Could that be something that we can explore?
That's definitely something I'm very interested in exploring.
Okay, great. So, I said at the very beginning of this hearing, I thought, like, one of the very, Jaren Hale Lockridge was testifying, and I said I thought one of the very interesting data points of all of the information that you shared was that in the last 5 years in the district, we've opened 20 new grocery stores. But for some parts of the city, they would never know that.
Exactly.
Because it doesn't sort of feel in that way. I've been trying to look at what other jurisdictions are doing to sort of, I don't know, crack the nut here. Like, are there things we haven't tried yet? And that are for jurisdictions that are similar to ours that we could be learning from? Who should we be looking at? Who's doing this better?
Yeah, well, I will say that I don't think anyone has completely cracked the nut, but I do think that there's some examples for us to learn from. I think one is really building off of what we've already done with Healthy Corner Stores, which is moving corner stores to sell some produce. Indianapolis has actually gone a step further, invested in staff to be providing technical assistance to these stores, providing small amounts of funding to be able to upgrade cold storage, to be able to really make those changes. And we've done a lot for cold storage between the Food Waste Innovation grants and Nourish DC's Keeping It Cool grants. We've allowed businesses to improve their cold storage, but making those investments tied with technical technical assistance that's actually making people have those purchasing connections where they're able to get really low cost, not just produce. Again, Healthy Corners has been incredible to expand produce, but we need to be expanding other lower processed food options. Even as a very plant forward person, I need food other than produce if I'm trying to make a complete meal. And so thinking about how we're getting more of those. In the past, in the district and in many other places in the present, many small grocers cooperatively purchase together. In the peak of the district's small grocer era in the 50s and 40s, we had Black-owned cooperative grocery stores that were collectively purchasing together. So dozens of stores were purchasing. I think there's other cities that have also looked at this longer term funding. Unfortunately, net, the numbers you said are correct, but we have seen a grocery store open and then close in Ward 8 as well as in Ward 5 with Aurora Market. And so I think that it is really important for us to look at how we're doing long-term funding. I think this kind of local matching where we're guaranteeing for the next 5 years, we're going to be providing $500,000 to these stores for this kind of produce matching, that has had some success. And the last thing I'll say, Chicago got a lot of publicity by doing a study around a municipally operated grocery store. And there's been some conversation about how potentially the commissary network, we run grocery stores. It's quite different. And in the end, where I haven't seen Chicago's final study, it's not public, but where they're looking is not the idea of the city buying and selling individual cans of beans, but actually how are we constructing space that we are then leasing out? And we have a huge opportunity we haven't tapped into for that. In some of the plans for renovations and community feedback in rec centers or in public schools that are being redesigned as community centers, even with letterer in the coming year, if we look at a capital investment in letterer, there's a possibility of us using district space to actually lease out to stores.
I know, but I guess I'm less convinced and or inspired on that one, just in that East Capitol Gateway, for instance, was going to be a project where we built the store, and yet we still haven't been able to even get to the eminent domain process, you know what I mean? And so I think what you're saying though around the small format grocery store is one that's very interesting and appealing. And I think Healthy Corners is like one of our, it's not our best. I don't want anybody to get jealous. But I do think that it is probably a program that we could truly expand on more if we thought about it. And really try to make investments. The cold storage issue is certainly an issue. We've heard that. I've heard that from DC Central Kitchen, right? Like folks needing some investment or funds to be able to do the refrigerated items because they didn't have that space that's available to them. I think we also don't necessarily do a very good job of promoting these locations in the neighborhoods so folks kind of know, hey, there's more than chips, candy, and soda here. You can get tomatoes and onions and milk or orange juice or, you know, some of these other products that you might need. I feel like for some folks though, like they want to just go to one place to buy all the things.
100%.
And small format grocers don't really lend themselves to that. I think also one of the issues that we've had with some of the stores that have opened and closed is that they have had more of a niche variety in their offerings, if that makes sense.
Yeah, I think that really thinking about what we're offering and how those stores are offering it, I think that's why Indianapolis is really inspiring to me in terms of how we're having people with grocery expertise who we're supporting to provide technical assistance to these stores as they really think about what they buy, how they buy it, and where they sell. I think the other piece related to that is also thinking about transportation. Both of those, the Good Food Market site and the previous, Yes Organic in Ward 7 many years ago, one commonality between both of those was thinking about transportation. And I do think that's why not continuing to think about that. There's now potentially 2 grocery stores that are in conversation with developers close to the Benning Road metro station. And I think that thinking about how we have grocery stores near or even in a metro station, which of course that would have to be smaller, but the district has plans to renovate every single metro station in the next 10 years to make them more climate ready. How do we think about food access in those points as well? If we're redeveloping them, we know that people need to be able to access their grocery stores, not just by car, but if they're driving, there needs to be parking, and that that we have it be public transit accessible.
Yeah.
And so I think those are exciting. And the other thing that I've heard from the developers who are considering those sites is anytime that there is a change in any way to the development, they have to go back through the development review process, which of course, I love my colleagues at OP who are doing that. And for the grocer, it can be really challenging to not know what the timeline is.
Oh, yeah.
So
I think that is probably, the McMillan site is probably a key example of how timelines can truly throw off the ability to make those connections. As you know, DMPED recently introduced a resolution to expand the supermarket tax incentive to downtown and parts of Ward 5. I guess I'm trying to get at what conversations, if any, DMPED is having. So I'm going to ask the same question to the deputy mayor, but I'm very curious. Did they ask the Food Policy Council or OP around what is the best areas for this expansion? Or did they make their own analysis and determination?
I think the priorities of the revitalization of downtown is obviously a priority that the district has set, and expanding it there, we know that we are going to need to have more grocery stores to serve those residents. In terms of also addressing the grocery store needs in Ward 5, to be honest, I think we're all clear that if this is an incentive that can bring a grocer, wonderful, but what we're seeing is it's not moving the needle.
Yeah.
So we need to be looking at other investments rather than the exclusively the tax abatement to bring more grocery stores to Ward 7 and 8.
I think that's accurate. I do feel like for folks who live in certain areas, as they're hearing about, oh, such and such got another tax incentive for a particular area, that it's a nice to have, but it probably wasn't necessary in order to close the deal. Right? I think of the supermarket tax incentive as like the whipped cream and the cherry on the sundae, but it is not the ice cream base, right? In terms of making the decision, it is just a sweetener on the top.
I think it also really, one last thing on that is I think it only really serves our largest grocers. What we've heard from small format grocers is the requirement that if someone is moving into a space that is already occupied, that they need to make a 50% investment in the renovations
retrofit.
of the space.
Yeah.
And for a grocer who's moving into another grocer space, you're never going to make that kind of investment. And so they're then not able to access the tax incentive in a way that our goal was to be able to encourage grocers to stay long and to move into places that need food access, some of which are, yes, in existing developments, not just the newest ones.
Yeah. Okay. You highlighted the success of the Nourish DC program in your testimony, which I think is a lesser well-known DMPED program other than the Food Access Fund. Has Nourish DC funded any grocery stores since it's been in operation?
I would need to get back to you, but I do know that both Market 7 and the Dreaming Out Loud Marion Barry site have received Nourish DC technical assistance, if not funding.
Okay, that's good to hear.
And certainly the Keeping It Cool grant, which is run by Nourish DC, has also funded grocers.
Okay. So you talked a little bit about the need in terms of transportation, which I agree. I introduced legislation on this topic last year around a transit study, particularly as it pertains to food access. We weren't able to move forward with it because DTOT informed us, was like, oh, we're going to include this type of analysis in our Better Bus study. That didn't exactly occur. And so I do think that there is probably more research needed on this front. Is this something that the Food Policy Council would be interested in exploring?
Absolutely. And I think seeing when that study was not funded, but really agreeing that it very much needed to be, we are working to figure out how to get the necessary capacity to be able to do that. So in conversations, certainly within our district agencies, DDOT, WMATA, the Office of Planning, but also the Metropolitan Washington Council of Governments, which I think we're so aware. And I think that the little piece of that study that we did was just laying on top transit maps and food access maps to highlight this number that I shared earlier of the high percentage of residents in Ward 7 and 8 who are both half a mile from a grocery store and half a mile from any bus line or metro station. We want to go further than that. And I think we've seen our transit agencies do incredible mapping around layering of information. And I think we can do more of that.
Okay. So last week, days feeling like weeks. It was literally just last week. There was a performance oversight hearing for the Department of Consumer Licensing, Licensing and Consumer Protection, DLCP. And I'm not sure if you watched that hearing, but there was a significant amount of conversation about street vending and the programs therein. My understanding is that DLCP and DC Health are in some conversations around making adjustments to the program and otherwise. And I'll admit, I don't think that it is the most streamlined approach, especially, and nothing can ever be that streamlined when you have two agencies who are engaged in the licensing process. Are you part of the conversations around, how we can make this more successful for implementation?
Yeah, so OP and the food policy team within OP were involved in the vending study that OP conducted, and that included many conversations with the LCP, DC Health, and lots of bilingual conversations with street vendors. So while we don't have a role in implementation or any authority around the creation or enforcement of the regulations, we have been in conversation with both agencies and with the vendors. And I think what the study puts forward are potential solutions that could bring all of our priorities together. We all want, including the vendors, to maintain public health, food safety, and the mobility of passerbys. We all want the same things. And we really tried to make sure that in that vending and public life study, we are lifting up some of those recommendations.
Okay. I think that's something we're gonna, the conversation on street vending is not over.
Correct. And I look forward to we're eager and willing to be a part of really thinking about when DC Health and DLCP have clarity about the order of operations, we're thrilled and eager to lift up that. And I am really excited. Again, one of the things I'm most proud of is bringing DLCP into the Food Policy Council as an ex officio member. And as a part of the Entrepreneurship and Food Jobs Working Group, DLCP staff are working to create a really clear pathway of all of the different paths that exist for a food business right now to be able to register and what that licensing pathway looks like.
Okay. You mentioned in your testimony that the Department of Energy and Environment Urban Agriculture Grant Program has more demand than funding. As I understand it, only about a third of applicants actually receive funding each year, which I think is, that's a interesting sort of acceptance rate. What type of entities does this grant program fund?
I would have to get back to you on exactly the grantees in the last year, but the Urban Agriculture Infrastructure Grant supports some of our existing commercial farms in the district, but also community gardens and community operations that are at any different kind of level, nonprofit farming or just farming for community benefit. And so it really does benefit a wide range of growers. And it's been, it's something that has just continued to come up in food policy conversations with growers, the need for these investments in infrastructure, especially when you think about a water connection can be $2,000, which if you are a pool of neighbors trying to turn this lot into a garden, that's a massive investment. And long-term irrigation, some of those other things that can really make a garden thrive have been especially when the land is perhaps leased from the district or in another way like that, the tax abatement program, as wonderful as it is not the only thing that those farms and growers need. So the importance of having both the grant program and our tax abatement really allow us to be growing on a wide range of land.
That's great. I worked on that back in the day when I was a staffer. So I want to ask, I guess, the elephant in the room question. Right now, for your office within OP, how many different federal grants do you all have?
Our office specifically is only right now reliant on the Resilient Food Systems Infrastructure Grant I mentioned, which was to fund a full-time 2-year position in my office. That's the only grant funding specifically that comes to my office.
Okay.
But when we look at the food system and everything that we cover in our food access and economy report,
Right.
there are dozens of federal grants that district agencies and our partner nonprofit organizations rely on.
Okay.
I'm happy to outline some of them now, but I'm also, in the interest of time, willing to send them to you for that list.
Yeah, no, I mean, that would be helpful to have the full list. I think because you mentioned, while you did talk a lot about the Regional Food Systems Infrastructure Grant, I think you also mentioned a food business center grant.
Yeah, absolutely. So our team we're not going to receive any funds from that, but I'm on the advisory committee for the Regional Food Business Center, which covers, the district is included in the entire Northeast. And those applications, we just went through the first application round for technical assistance providers, where millions of dollars went out to technical assistance providers.
Mhm.
But there's the other piece, which will be the going to exactly to food businesses. So both Resilient Food Systems Infrastructure and the Regional Food Business Center grants are all reimbursement grants. And I think lots of people don't recognize that even when we look at grants that say they were awarded in 2024, organizations are only paid back when they submit their receipts. And so it's not as though the federal government already sent us all these checks and we're in the clear. And so I think that so many of these programs, and we're in touch with lots of our partner organizations, again, agencies and nonprofits that rely on federal funds to get food to people. We're following it really closely, and we are certainly trying to keep everyone informed as we learn more.
Great. Well, again, still clear as mud on what's happening there. All right. I want to ask some basic questions about just the operations of the Food Policy Council.
Right.
So by statute, you all are required to hold at least 6 public meetings a year. Did that happen?
Yes.
How many meetings did you hold?
We had 6 public meetings in 2024.
Okay. You also have 12 public members. How many vacancies do you currently have?
We have 1 vacancy at the moment.
Okay. In terms of the attendance of said 12 members, did you have any challenges meeting quorum?
We never had a challenge meeting quorum.
Okay.
And we have put some more processes in place to keep people informed about when they are reaching our attendance thresholds, and making sure that people know we do all of our meetings, while we've moved to in-person, have been hybrid, so that folks who are not able to attend for health or other reasons can still join in to listen.
Okay. Give me just a second. Is there anything I haven't asked you that you want to mention for the record?
I appreciate that opportunity. I would say that the only, we've covered a lot today, and I appreciate that. I think that the only piece that I have potentially not is that we're really, I touched on the 1115 waiver briefly, but I think given potential changes to Medicaid, we're going to be following really closely what unfolds with that, and how we will need to maintain that we're supporting food as medicine, whatever happens with 1115. And I also want those listening and you, council member, to know that the systems we put in place during COVID to be able to convene emergency food providers, to be able to make sure that we are directly in touch with the nonprofits who are getting food to folks who are in the most employment challenges, and in cases the food team also did this during the federal furlough. We're prepared and ready to make sure that people know all of the ways that they can get food. And we have systems in place that, should we end up in an even more challenging food environment, that we're ready to bring those partners back together to share the information that we need.
Great, thank you. Thank you to all of the public witnesses who provided testimony today. I think we have some follow-ups, but we'll send those over to you around some of the data points that we're looking for. I want to thank you. I do want to thank Director Kaufman, who was here earlier, for providing testimony and engaging in this very robust conversation that we just had. For those of you in the public who are listening, who wanted to submit your written testimony, or you were not able to speak today or attend today, but you want to submit written testimony, we'll accept public testimony until February 12th at 5 p.m. You can submit your written testimony online on the council's hearing management system website, dccouncil.gov/hearings. The committee's next hearing will be on Monday, February 3rd. We will hear from public witness testimony for the performance of the Department of Behavioral Health. The time is 2:48 p.m. and this hearing is adjourned. Thank you.
Thank you so much.